Hello everyone, a very good evening to all of you. I'm Dr. Sanchit. I'm your PW MedEd ENT faculty, and we've been doing one scenario based approach, right? We've been going through a lot of clinical based questions in various subjects, and especially to related to ENT, I would be focusing on a lot of clinical scenarios which will be regarding how to diagnose and how to approach specific questions related to larynx. So I have got important 12 scenarios for you. This is not only going to be an exercise for your NEET PG exams, but this is also going to be an exercise for you in order to understand how to approach these questions, how to get the right answers. So I have got various 12 scenarios, I've got MCQs, I've got image-based questions to it. We are going to see one by one about the whole of approach, and we are going to make it very, very simple, right? So in this particular segment, I'm going to deal with what exactly are the important clinical scenarios related to larynx. And we're going to go into every scenario possible, and we are going to have a chat about it, we are going to discuss about it, and I would request whenever you know the answer, please write it over on the chat box. I would know that you guys have understood, right? Chalo. So now let's move on to the first scenario of larynx, and this is going to be the type of questions that you will get. Yes, good evening Shreya, good evening to all of you. Welcome to ENT Masterclass, right? So this is about a story of a 40-year-old singer by occupation, a male who is singer by occupation, presented to the OPD with complaints of change in voice, that we could say that there is hoarseness of voice, and it is lasting for the past 20 days. He also gives a history of GERD since the past 10 years. So we have got one more important history, that the patient has got GERD. And the patient, because of GERD, has got repeated throat clearing. Throat clearing का मतलब जब भी GERD होती है, the patient says this is a kind of throat clearing the patient has, right? Now, a video laryngoscopy was done. हमने इसकी video laryngoscopy करी, and what we saw was, we saw this kind of a picture. हमें ये मिला इस video laryngoscopy से. So what we have got as on the basis of history, हमारे पास history में we have got a male who is singer by occupation, who has got a repeated throat clearing, and he is a known case of GERD. And they have shown you कि ये इस type की laryngoscopy picture है. This is what they have shown you, right? Now, on the basis of this picture, what is the probable diagnosis of this patient? We are going to approach this now. Is it vocal nodule? Is it vocal polyp? Is it about a granuloma? Or is it about Rinke's edema? What are they trying to ask you? First, see the question and try to figure out what they have given you. So, I am talking about a singer here, right? The first point is that we are talking about singer. Many of the questions might say that this is a teacher. Many of the points might say that this is a chronic voice abuser. So these are the pointers that they have given you. Chronic voice abuser, teacher, or a singer. Second thing that they have told you is this person has got GERD or a patient has got repeated throat clearing. So any patient, any question, you have got a history of almost constant use or voice abuse, and they have come with hoarseness of voice. When you see the laryngoscopy, you see bilateral symmetrical lesions on both the vocal cords. अब हमने क्या बोला? We are seeing two lesions over here, one swelling over here, one swelling over here. What does that mean? That means this is a bilateral symmetrical lesion at the junction of anterior 1/3 and mid 1/3 of the cord. You can see that this is at the junction of anterior 1/3 and mid 1/3 of the cord. Now my question is, what exactly is this vocal cord? और ये यहाँ पे क्यों होते हैं? Right? This is one thing I want you all to understand. Before we move on to many other diagnoses, हम लोग यहाँ पे कुछ basic understanding करते हैं. If I take this vocal cord out and I draw it for you, तो vocal cord में कुछ इस तरीके का structure होता है. This is how a vocal cord looks like in our real life, right? Vocal cords are divided into an anterior 2/3 part and a posterior 1/3 part. Every vocal cord of our, whatever is there in the larynx, both of them are divided into an anterior 2/3 part and a posterior 1/3 part. Anterior 2/3 part of the vocal cord is given the name as membranous vocal cord, and the posterior 1/3 of the vocal cord is called as cartilaginous part of vocal cord. Why it is cartilaginous? Because it is containing the vocal process of the arytenoid cartilage. There is vocal process of the arytenoid cartilage, which it is containing. So posterior 1/3 has got to do with cartilaginous part, anterior 2/3 has got to do with membranous part. अब अगर हम एक चीज देखें, जब भी आपको कोई भी वोकल पैथोलॉजी पूछते हैं, the first and foremost thing you should understand, all vocal pathologies occur in the anterior 2/3 of the vocal cords. They never occur at the posterior 1/3. कभी भी voice change आए, this is the anterior 2/3 of the vocal cord they are talking about, because this is the part which vibrates. That is why it is called as membranous part. अब एक काम करते हैं, we are going to take out one piece of this vocal cord out. अब इसको मैंने बाहर निकाल लिया, and I am going to show you the various layers of vocal cord. Vocal cord की कितनी layers होती है, we are going to see that, right? So when I see about the layers of vocal cord, the innermost layer is called as vocalis muscle. Okay, above the vocalis muscle there is something called as deep lamina propria. Deep lamina propria, lamina का मतलब sheet, propria मतलब layer. Above the deep lamina propria there is a layer which is called as intermediate lamina propria. Above the intermediate lamina propria we have got a layer which is called as superficial lamina propria, and above the superficial lamina propria we have got epithelium. These are the 5 layers of vocal cords: epithelium, superficial lamina propria, intermediate lamina propria, deep lamina propria and vocalis muscle. तो इस चीज से what do we derive, what understanding do we derive of the vocal cord, कि इसकी 5 लेयर होती हैं. Intermediate lamina propria and the deep lamina propria together are given the name as vocal ligament. They are called as vocal ligament. So intermediate and deep को together क्या बोला जाता है? This is a very important question. They are called as vocal ligaments. अब अगर एक चीज हमारी अंडरस्टैंडिंग में आई, what is that? That vocalis muscle and vocal ligaments are hard. They are hard. So always remember that our vocal cord has got something called as a body and there is something called as a cover. And this is what is the understanding सारे vocal disorders की, which is called as cover and body theory. Cover and body theory से क्या मतलब आता है? Cover का मतलब the epithelium and the superficial lamina propria are the cover and vocal ligament and the vocalis muscle are the body. मतलब whenever we speak, it is actually our vocal cord is not vibrating like this. Our cover is moving over the body. Our cover is vibrating over the body. So the cover is giving us the vibrations, whatever we are speaking, and the body is giving us mechanical strength, जो adduction, abduction में काम आती है. This is what is called as cover and body theory. अब इसके बेस पे we will understand what is Rinke's edema, we will understand what is vocal nodule, we will understand what is vocal polyp. तीनों चीजें यहीं पे खत्म हो जाएंगी. Now see what is the understanding of all three. Okay. Now imagine ये एक सिंगर है, ये सिंगर बहुत टाइम से है, and this particular singer has been singing since a very long time, टीचर है, chronic voice abuse है. So what is going to happen? These vocal cords are going to again and again shut. ये बार बार shut होते रहेंगे. Now when they are going to again and again shut, the anterior 1/3 and the mid 1/3 junction of both the vocal cords is going to strike the maximum. Anterior 1/3 and mid 1/3 of the cord is going to strike maximum, and that is why this junction is called as striking zone. It is called as striking zone. और क्योंकि ये striking zone होता है, that is the reason why maximum friction happens in this area. तभी vocal polyp, vocal nodule both happen at the junction of anterior 1/3 and mid 1/3 of the cord, because it is the maximum strike zone. It has got the maximum friction. So हमेशा देखना, if they have made a lesion at the anterior 1/3 and mid 1/3 of the cord, there could be only two possibilities. That would be one, it is a vocal nodule. Two, it is a vocal polyp. Because both of them are occurring because of voice trauma or phonotrauma. Okay, fine. Now we understand कि ये होगा कैसे, right? ये vocal nodule हुआ, अब ये हुआ कैसे? So ये टीचर है, ये बहुत टाइम से गाने गा रहा है और बहुत टाइम से पढ़ा रहा है. So what is going to happen? There are certain blood vessels which are present beneath the epithelium. There are certain blood vessels which are there beneath the epithelium, right? And these blood vessels get injured. They get injured because of constant voice trauma. When these blood vessels get injured, there is going to be leakage of blood. और जब blood निकलेगा तो body इसको heal कैसे करेगी? Body will send fibroblast in order to heal it. So now the body will send a lot of fibroblast in order to heal this area. And if this particular fibroblast comes, fibroblast क्या करते हैं? They create fibers. So when they create fibers, they will create these kind of hard nodules. So always remember, whenever you find a vocal nodule question, you will have bilateral symmetrical swellings at anterior 1/3 and mid 1/3 of the cord, and they will always be less than 3 millimeters. So they are less than 3, bilateral, anterior 1/3 and mid 1/3 junction, and that occurs due to the fibrosis that happens over on the vocal cords because of constant trauma. Second important thing, they will always give you singer, teacher, as in the question. Third important thing, they will always tell you repeated throat clearing or GERD, because these cause a repeated throat clearance in these cases. There is something stuck in my throat, that will be their complaint, right? What will be the treatment if they ask you what will be the approach of management? अब आप अगला क्या करेंगे? Always remember, vocal nodule is a medically managed condition. We don't operate on vocal nodules unless and until professional voice users are there. First line of management is medical. If a patient wants medical management, what can we do? 4 things we can do. First is most important, absolute voice rest. Absolute voice rest is the first thing that we do in cases of vocal nodules. Second important thing that we will do in these cases is we will give them proton pump inhibitors. Why? Because the patients usually have GERD. Right? Third, we will always give them a course of antihistamine. Antihistamines. Right? So GERD is, yes, GERD is associated with throat clearing, right? सुतापा, क्योंकि ऐसे सोचो कि suppose if somebody has got GERD, right? तो उनकी acidity यहाँ तक आएगी, somebody will always do. तो ये repeated throat clearing ना, this happens in allergy also, this happens in GERD also. And that is why we have to give them antihistamines plus proton pump inhibitors. We also have to give them mucolytic syrups. We also have to give them mucolytic syrups. Okay? So this is all what you require as far as this particular management is concerned. Okay? Fine. So what exactly is the management? Keep them on absolute voice rest, give them proton pump inhibitors, give them antihistamines, give them mucolytics. Surgery is not the first choice. क्योंकि जब हम सर्जरी करेंगे तो vocal cord पे scarring ज़्यादा होगी. Whenever we operate, we create scars. Vocal cord will scar, will create worsening of voice. Okay? So this is about what you need to know as far as vocal nodules are concerned. चलो, अब इसी सिनारियो के बेस पे एंड इसी बेसिक के बेस पे जो हमने बनाया है अबाउट द कवर एंड बॉडी थ्योरी, वी विल ट्राई अप्रोचिंग अदर क्वेश्चंस एज वेल. ओके, नाउ दिस इज अबाउट अ 60-year-old chronic smoker. First important clue that this is about a chronic smoker, right? And that patient presented to the OPD with complaints of change in voice since the past 3 months. A chronic smoker जब भी आता है, 2 things come in my mind. One is Rinke's edema. Second is carcinoma larynx. Carcinoma malignancy very commonly associated with smoking. Second, smoker से associated एक ही disease होती है which causes heaviness of the vocal cords, that is called as Rinke's edema. अब ये क्या होता है? We'll see that. But just imagine 2 चीजें important है that occurs in chronic smoking. Now, we did a video laryngoscopy और video laryngoscopy पे कुछ इस तरीके की image मिली. We saw this kind of a picture. Okay, very good. Sheetal has already answered. This is Rinke's edema. अब क्या होता है Rinke's edema? Let me come back to what I taught you. Okay, vocal cord की कितनी लेयर होती हैं? vocal cord में सेंटर में होती है vocalis muscle, उसके ऊपर होता है deep lamina propria, उसके ऊपर होता है intermediate lamina propria, then comes superficial lamina propria, then comes epithelium. These are the 5 layers of vocal cords. And I told you just below the epithelium there are blood vessels. There are blood vessels below the epithelium. Now if I ask you what is Rinke's space? Rinke's space is nothing but this superficial lamina propria. ये जो superficial lamina propria मैंने लिखा हुआ है, this is nothing but this is also called as Rinke's space. This is called as Rinke's space. Now imagine what is happening. Again, now this patient has been chronically smoking, so bar the cigarette smoke is going inside in his vocal cords again and again. What will the smoke do? Smoke will cause fragility of these vessels. ये vessels टूटने लगेंगी. And when the smoke will cause fragility of these vessels, all the inside capillary permeability will start increasing. मतलब leak करने लगेंगी ये capillaries. So if the capillaries will start leaking, they will start forming fluid between the epithelium and superficial lamina propria, which is also called as Rinke's space. And if this particular Rinke space has the edema, we call that as Rinke's edema. अब Rinke's क्या होता है? It was Frederick Berthold Rinke who first found that this layer is present in the vocal cord. His name was Frederick Berthold Rinke, who first actually saw what is Rinke's space. And since then, any edema of this space or superficial lamina propria is given the name as Rinke's edema, in simple words. Okay, so this is what is Rinke's edema. Now, what do you see over here? You see there is a chronic irreversible swelling over the vocal cord. This is a chronic irreversible swollen cords. फूल गए कॉर्ड्स, राइट? बिकॉज नाउ दे आर इडीमेटस, क्योंकि उनके अंदर कैपिलरी परमेबिलिटी इंक्रीज हुई है, कांस्टेंट इरिटेशन हुआ है, एंड नाउ दे हैव कॉज्ड दिस काइंड ऑफ अ स्वेलिंग टू फॉर्म इन बायलैटरल वोकल कॉर्ड्स. So what will be the problem or what will be the complaint this patient will have? Always remember, this is a problem which happens more in females than in males, and usually it happens in smokers. That is why it is also called as smoker's larynx. It is also given the name as pseudomyxomatous laryngitis. These are the two names. Now, what do you understand by this? Pseudomyxomatous means there is jelly-like fluid within the vocal cords, right? Now, if there is jelly-like fluid over on the vocal cords, what will be the complaint of the female who has it? The complaint will be, जब भी हम vocal cord को heavy कर देते हैं, हमेशा हमारी आवाज नीचे चली जाती है. So my voice is very, very heavy. This is how my voice will become. It will become very, very low. It will become very, very dense. तभी इसमें आपको question क्या आएगा? They will always say that a female is sounding like a man over on the telephone. ये question आएगा कि telephone पे female is actually sounding like a man because the heavy vocal cords have, causing that problem to get down the tone. Right? When we stretch the vocal cords, हमारी volume increase होती है. जब उसे हम भारी कर देते हैं, so we actually go down, much more down. Right? That is what is the complaint of these patients, right? So what will be the clinical features that they will give you? The clinical features that they will give you in this particular condition will be that these particular patients will have gruffy voice. Gruffy का मतलब क्या होता है? Very harsh voice. They will have choking episodes. They will have choking episodes. They will have decrease in pitch. That means the female will start sounding like a man, right? And if this Rinke's edema becomes very big, then that can also lead to respiratory obstruction. It can also lead to respiratory obstruction. अब Rinke's edema के क्या causes होते हैं? First and foremost cause Rinke's edema का I've already told you, it is smokers. But one more important cause that is there in Rinke's edema is hypothyroidism, because hypothyroidism में there is edema inside the body. Right? And there is also allergy. So allergy, hypothyroidism, smoking, most common causes which can lead to this particular cord to become irreversibly swollen. Now, how will we treat it? Rinke's edema also follows two lines of management. First and foremost is medical. Medical is same as I told you in vocal nodule. What will we do? We will tell absolute voice rest. We will tell about avoid and quit smoking. If you are a smoker, we will tell the patient to start proton pump inhibitors. We will start treatment for antihistamines, and we will also control the thyroid profile if the patient is hypothyroid. But at the same time, we need to be also understanding that this is something which is irreversible. So we need to take out this fluid, and what do? We do something called as reduction glottoplasty. Reduction glottoplasty. Reduction का मतलब obviously reducing the size. Glotto मतलब the vocal cords. Plasty मतलब repair. Right? So Irtika is saying stripping. Stripping is not done nowadays. Stripping का मतलब होता है we take away the epithelium out. Right? So we don't do that. Right? So what do? We usually put an incision over bilateral cords, over the epithelium. We open these vocal cords up like a book. We take out and suction out all the fluid which is present in this Rinke's space, right? And by this simple exercise, we will be able to reduce the bulk of the cords. Okay? So Tapa is asking about Rinke's edema. क्यों बोलते हैं? It is because of Frederick Berthold Rinke, who actually was the first one who saw this edema to happen. right? That is why it is called as Rinke's edema. Other name for Rinke's space is superficial lamina propria. Right? What is the procedure that is done? It is reduction glottoplasty. It will give us a smooth margin and a smooth edge of the vocal cords. Okay, fine. So this finishes our one more important question. The answer of obviously this particular condition, you have got change in voice, chronic smoker. Here is, it happens to become Rinke's edema. Okay, fine. Chalo. अब आते हैं तीसरे larynx के scenario पे. Now this is about a 30-year-old male politician. Politician मतलब obviously यहाँ पे उन्होंने पहला clue दे दिया. The first clue is what? That the patient is a voice abuser. That is the first clue. Presented to the OPD with complaints of change in voice since the past 10 days. 10 days ka I can understand that this is an history which is quite acute. This is not something which is chronic, right? This is acute history. 10 दिन की history है. And his voice had considerably changed post speech delivered in his last rally. अब रैली के टाइम पे पॉलिटिशियंस क्या करते हैं? दे जनरली शाउट अ लॉट, राइट? तो दैट मीन्स इसने रैली में गया, ही गेव सम स्पीच एंड देन सडनली इन दीस लास्ट 10 days he has some kind of a voice change. Now, you have been given about a video laryngoscopy. I'm going to show you what the video laryngoscopy image is. This is how the video laryngoscopy looks like. अब इस पेशेंट को हुआ क्या? राइट? वोकल नोड्यूल मैंने आपको पहले ही बताया था. वोकल नोड्यूल आई टॉट यू इन द फर्स्ट. Right? Vocal nodule में क्या था? I told you that was chronic abuse since many years. Right? And I also told you that is something very commonly seen in teachers, very commonly seen in cases of singers. This is something which is quite acute. 10 दिन की history है, sudden shouting की history है क्योंकि रैली में गया था. What do you see on video laryngoscopy? On video laryngoscopy, you see दोनों vocal cords, you see both the vocal cords, right? You see that there is something wrong at the junction of the anterior 1/3 and mid 1/3 of the cord. There is something wrong at this junction. And this is only on one vocal cord. You cannot see anything on the opposite vocal cord. Right? So you can see that there is a lesion which is present at the junction of anterior 1/3 and mid 1/3 of the right vocal cord only. What is the answer? Correct, Vidushi. It has to be vocal polyp. This is vocal polyp because only one thing is involved, not two. So always remember one thing, what is the difference between the history of nodule and polyp? Nodules have chronic voice abuse. So let me just put a nodule over here. Polyps always usually come with sudden voice abuse. That is the first thing that you will have to see in history. Zor se chillaya, they might be candidates for a polyp, right? Vocal nodules are bilateral. Polyps are usually unilateral. They can happen bilaterally, but most commonly they are unilateral. Okay, fine. That is another important thing. Vocal nodules are always sessile. Sessile का मतलब क्या होता है? Sessile means flat based. If I just go back to show you how the nodules were, if you see here, let me just take this off and show you. See this. This looks like a flat base, right? This looks very flat. It has a flat base. This is called as a sessile swelling. But polyps are not sessile. Polyps are pedunculated. If you see this swelling, I've drawn it with a stalk. ऐसा दिख रहा है, right? It is coming out like a protrusion with a stalk. This is a polyp. So if nodules are sessile, polyps are pedunculated. This is another important point. Okay. Vocal nodules will always be having something which has got related to teachers or singers or mothers. This is something which is usually seen during a sudden scream. Okay, right? Another important point, another important differentiation between the two. Both occur at anterior and mid 1/3 junction. Okay, vocal nodules will be usually grayish white in color. They will be usually grayish white. Polyps usually will be pink to red in color. Why? Because we are having a hemorrhagic pathology. It's because of the hemorrhage that has happened over in the vocal cords, right? So they will be pinkish and red, they will be grayish white. Now if I ask you, you tell me what will be the management of a vocal polyp. I told you, if I tell you nodule, your first line of management is always medical. If I tell you polyp, your first line of management is always surgical. क्योंकि ये एक pedunculated polyp है. It is coming with a stalk. So that means when you're breathing, it is going in. When you're breathing out, it is coming out. So this moves with respiration. Now the problem is if you don't take it out, if you leave it like that, accidentally it might break. That is called as auto amputation. तो अगर ये गलती से टूट गया, it will go into the lungs and it will cause that kind of aspiration to happen. Correct? Right? So this is something which is the one why the first line of management in cases of polyp is always microlaryngoscopy and excision, and in cases of nodules it is always the medical line of management which I taught you. Now Vidushi is asking how the anterior and mid 1/3 junction. It's always remember one thing. I just taught you that. Always remember one important clue. Vocal cords, whenever they strike together, they strike very, very hard or firm at the junction of anterior and 1/3 and mid 1/3 of the cord. That is why this particular zone is called as striking zone, because यहाँ पे सबसे ज्यादा friction होता है. Maximum friction happens at this area, and because maximum friction यहीं पे होता है, सबसे ज्यादा यहाँ पे impact आता है. That is why when the vocal cords suddenly shut, it might lead to a hemorrhage in the vocal cords, producing these conditions. Right? So always remember, nodule, polyp दोनों anterior 1/3 mid 1/3 के junction पे ही मिलेंगे. That is the area where you will get these pathologies. Nothing else, nowhere else. Okay, fine. So this is about what I have taught you about 3 important conditions: nodule, polyp, Ringge's edema. Okay, fine. So what is the treatment for polyp? Microlaryngoscopy and excision, and that will solve the issue. चलो, अब आते हैं next scenario पे. Now this is something more. 35-year-old female underwent a surgical procedure, right, requiring general anesthesia and endotracheal intubation. Okay, endotracheal intubation हुआ. The intubation was relatively difficult. Now this is something important, and multiple attempts were made in inserting the tube. अब हो सकता है the intubation was difficult, they made multiple attempts, मतलब multiple times trauma हुआ होगा vocal cord को. That I can understand with this. Okay, so multiple attempts were tried while inserting the tube. Post-operatively, she experienced persistent hoarseness, a sensation of lump in the throat, and occasional throat clearing. That means again and again she's feeling something, and again she's doing this is the kind of thing that she's again and again doing. Right? ये हो रहा है उसके साथ, and she denies any prior history of any voice problem. मतलब जो भी हुआ सर्जरी के बाद हुआ. And now she has got a lump in the throat, she's feeling something is stuck in my throat, repeatedly she's trying to clear it, and she has some kind of a hoarseness of voice. Correct? That is what she has, right? And all of it has been post surgery. सर्जरी के टाइम पे एक ही प्रॉब्लम हुई, मल्टीपल अटेम्प्ट्स ऑफ इंट्यूबेशन हुआ, राइट? This is the video laryngoscopy of this patient. How this particular thing happened, or what is the video laryngoscopy particular picture of this image. Now what has happened to this patient? अब सबसे पहले मैंने आपको क्या बताया था? Whenever I say anterior and mid 1/3 junction, I was talking about vocal pathologies. I was telling you about nodule. I was telling you about polyp, क्योंकि ये एक chronic voice abuse की वजह से हुए थे. यहाँ पे there is nothing called as a voice abuse. यहाँ पे there is something what I can see at the posterior end of the vocal cord, not at the anterior end. Okay, Vidushi is saying C, Irtika is saying granuloma, Raj is saying polyp. Okay, let me just go back and see. So some of you think it is a granuloma, some think it's a polyp, right? अब again coming back to it, again coming back to what I taught you. जब भी आपको क्वेश्चन रिपीटेडली आए कि वॉइस अब्यूज से रिलेटेड है, वॉइस अब्यूज एंटीरियर 1/3 मिड 1/3 ऑफ जंक्शन, वाई? बिकॉज वो स्ट्राइकिंग जोन होती है, बट ये वॉइस से रिलेटेड नहीं है. दिस इज नॉट वॉइस अब्यूज, दिस इज समथिंग इंट्यूबेशन हुआ है, राइट? अब खुद सोचो, नाउ यू ट्राई टू थिंक. Below these vocal cords, you can see the subglottis and you can see the trachea, right? अब let's say I am the anesthetist, right? और मेरे हाथ में एक ट्यूब है, endotracheal tube, and I am trying to put in the tube, right? Now when I go or insert the tube inside, the area which gets maximum traumatized or irritated is the posterior 1/3 of the cord. Posterior 1/3 of the cord is the one which gets maximum irritated during intubation. तो अगर वहां पे इरिटेशन बार बार हो रही है, बार बार मल्टीपल अटेम्प्ट्स हो रहे हैं, देयर माइट हैव बीन इंजरी टू द पोस्टीरियर 1/3 ऑफ द vocal cord, and posterior 1/3 is vocal process of arytenoids. I told you that the posterior 1/3 of the cord is called as the cartilaginous glottis. Why? Because it contains the vocal processes of the arytenoids. Now if there is constant irritation, what will the body do? Body will start making granulation tissue. Body हमेशा granulation बनाती है as a response to any injury. So if this granulation keeps on increasing, it will form a granuloma. और तभी इसका नाम होता है इंट्यूबेशन ग्रैन्युलोमा, और वी ऑल्सो गिव दिस पर्टिकुलर एटियोलॉजी द नेम एज एरिटेनॉइड ग्रैन्युलोमा। तो एक इंपॉर्टेंट पॉइंट यहां पे क्या लेके जाना है, इफ यू सी एनी पर्टिकुलर पैथोलॉजी एट द पोस्टीरियर 1/3 ऑफ द कॉर्ड, इंट्यूबेशन रिलेटेड, क्लोज योर आइज, इट इज अ ग्रैन्युलोमा। दिस इज पोस्टीरियर 1/3। अगर आगे होती पॉलिप सोच सकते थे, but this is something which is posterior. Remember that this is the one which is getting irritated and traumatized during endotracheal intubation. Okay, so this answer becomes intubation granuloma or arytenoid granuloma. Chalo, now we move on to the next question. Okay, now this is something to a lower age group. A child, 6-month-old infant presents with a history of noisy breathing. That means upper respiratory obstruction. Noisy breathing matlab hota hai stridor, right? That's what is noisy breathing all about, right? And this worsens when the patient lies down on their back. That means when the baby lies down supine, that is the one which creates more of respiratory obstruction, right? On examination, we note the patient has got inspiratory stridor that improves when the infant is positioned in an opposite position. That means अगर infant को हम prone कर देते हैं, उसको पेट के बल लिटाते हैं, that is the point where the infant improves. Very important, ठीक है? Which among the following is the most likely to be the cause for the infant's symptom? So you have been given 4 options. हमारे पास क्या clue है? हमारे पास ये clue है that the patient has come in stridor which increases on supine position and decreases on prone position. This is a 6-month-old infant. And this stridor is called as inspiratory stridor. अब देखो यहां पे I want you to tell you very very important things, right? Inspiratory stridor का क्या मतलब हुआ? When the patient is inspiring, so the patient has got obstruction. When the patient is expiring, कुछ नहीं. तो मतलब only on inspiration there is a noise. पहला point. अगर स्ट्राइडर दोनों साइड पे होता है, दैट मीन्स इफ देयर इज स्ट्राइडर बोथ ऑन इंस्पिरेशन एंड एक्सपिरेशन, वी कॉल दिस एज बाइफेजिक स्ट्राइडर, मतलब दोनों साइड पे स्ट्राइडर है, इंस्पिरेशन में भी एक्सपिरेशन में भी. तो एक इंपॉर्टेंट चीज हमें यह समझ में आती है दैट इफ एनी पैथोलॉजी इज प्रेजेंट इन आवर सुप्राग्लॉटिस, मतलब वोकल कॉर्ड्स के ऊपर, इफ देयर इज एनी पैथोलॉजी, इट विल लीड टू इंस्पिरेटरी स्ट्राइडर. रिमेंबर दैट. If there is any pathology, अगर आपको कोई भी पैथोलॉजी मिल रही है at the level of vocal cords or below the level of vocal cords, that means subglottis and even the cervical trachea, they will produce biphasic stridor, क्योंकि all of these areas are closed. Closed का मतलब vocal cords के बीच में बहुत छोटी जगह है. सबग्लॉटिस इज द एरिया जो हमारे क्रिकोइड कार्टिलेज के विदिन होता है. क्रिकोइड इज अ क्लोज्ड रिंग, उसके अंदर के एरिया को वी कॉल इट सबग्लॉटिस. बिलो इज द ट्रेकिया. ट्रेकिया इज क्लोज्ड फ्रॉम ऑल अराउंड. So if there is anything which will lead to circumferential narrowing, it will lead to biphasic stridor. Subglottis में let's say subglottic edema हो गया, subglottic stenosis हो गया, subglottic hemangioma, subglottic tumor, they all are biphasic stridor. Correct? So supraglottis is inspiratory stridor. Vocal cord, subglottis and cervical trachea are biphasic stridor. Any particular pathology which is present over below in the thoracic trachea or in the bronchus, they are the ones which usually produce expiratory stridor. These are the zones of stridor. How we can understand? अब 6 month old अगर infant के inspiratory stridor है, because I have told you that this worsens particularly during feeding and it is a type of inspiratory stridor. What is the most common cause of congenital stridor? What is the most common cause of stridor in infants? ये हजारों बार पूछे जाने वाला क्वेश्चन है. Most common cause of stridor in infants has to be laryngomalacia, nothing else. Whenever you see infant with an inspiratory stridor, answer ultimately in your head should be that it is laryngomalacia. ये सबसे कॉमन चीज होती है, right? Now what is laryngomalacia? Let me just briefly tell you. So if we do a laryngoscopy of this particular patient, हमें कुछ इस तरीके की इमेज मिलेगी. Laryngo मतलब larynx, malacia मतलब soft. So that means our larynx is containing cartilages, right? And you can see this is also a cartilage. This is your epiglottis. These are your arytenoid cartilages. But you cannot see any vocal cords inside. There's a very small space. So what is laryngomalacia? In laryngomalacia, there are 4 problems which happen in a child congenitally. 4 चीजें होती हैं, 4 प्रॉब्लम होती हैं. one important thing is that the cartilages are flaccid. There is flaccidity of cartilages. That is the first problem with laryngomalacia. Second problem is neuromuscular incoordination. That is the second problem with laryngomalacia. Third problem is development of short mucosal folds. Fourth problem is that the patient has got redundant mucosa. Now, what is the meaning of all this? I'm just going to explain. This is how laryngomalacia occurs. First is flaccidity of cartilage. Flaccidity of cartilage का क्या मतलब हुआ? Cartilage are very soft. That means what? When the patient will inspire, the cartilage will curl. The cartilage will curl inside. So that is why when you see this epiglottis has become curled when the patient is inspiring. जब वो expire करेगा ये खुल जाएगा. So that is what is called as flaccidity. So this curling gives a sign which is called as omega sign or omega shaped epiglottis. That is the first problem with laryngomalacia babies, that when they are actually breathing, the cartilage or the epiglottis is curling, which is called as omega sign, which is a very important question. Or omega shaped epiglottis is seen in which condition? It is laryngomalacia. Most common cause of inspiratory stridor in infants, laryngomalacia. Most common congenital stridor, laryngomalacia. ये सारे questions हैं. Okay? Second is neuromuscular incoordination. That means muscles of the larynx are not coordinated well, so they undergo tonic spasm. वो spasm में आ जाती हैं and they try to close everything. That is what is called as neuromuscular incoordination. Third problem laryngomalacia में क्या हो रही है? The mucosal folds of the larynx are very, very short. We know that there is a fold which connects the arytenoid to the epiglottis, and this is called as aryepiglottic fold. There is a mucosal fold which connects the arytenoid to the epiglottis. अब इसमें देखो aryepiglottis fold कितने छोटे हैं. They are so small. If I just show you what exactly was the aryepiglottic fold, now see over here. ये vocal cord है. These are the arytenoids, right? These are the arytenoid cartilages, right? And you see that they are so big aryepiglottic folds. कितने बड़े हैं, right? But what exactly do you see over here? You see that these aryepiglottic folds have turned to be very, very short. And because they turn to be very, very short, suddenly the larynx becomes very small. फोर्थ इज रिडंडेंट म्यूकोजा. रिडंडेंट म्यूकोजा का क्या मतलब है? एरिटेनॉइड्स के ऊपर देखो बहुत सारा एक्सेस म्यूकोजा है. एक्सेस म्यूकोजा का क्या मतलब है? सपोज मैंने एक डबल एक्सएल साइज की शर्ट पहन ली है. आई एम वेयरिंग अ डबल एक्सएल साइज शर्ट और मैं एक जाके तूफान में खड़ा हो गया. तो व्हाट विल हैपन? सडनली माय शर्ट विल स्टार्ट फ्लैपरिंग, फट 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 फट, राइट? So that is how this redundant mucosa, the excess mucosa, when the child will breathe, all the mucosa will start flapping inside, and that will lead to more obstruction. So because of these four causes, it leads to this congenital anomaly which is called as laryngomalacia. Okay, fine. Chalo. Now, how exactly this is going to be your scenario? आपको मैंने एक और point दी that when the child is lying supine, अब सोचो ये child ऐसे लेट गया. When you lie down supine, your epiglottis falls back. So your symptoms will worsen. तभी अगर हम बच्चे को उल्टा कर देते हैं, if you turn the child उल्टा, prone, the epiglottis will fall forward and the child will breathe better. That is why we always say prone the child. Proning करिए. Okay? Now, these are the clues in which laryngomalacia can be solved. What will be the clinical features of this child that will be given to you? The clinical features of laryngomalacia, number one will be inspiratory stridor. Number two will be that the patient usually turns cynosed on supine position and during feeding. Third important thing is this particular condition improves during proning, and this also improves during whenever the child starts to cry. It will improve. Why? Because suddenly when the child starts crying, they will expel out a lot of air and suddenly there will be a lot of space. So that is how this child will improve. Now my question to you all is, how will you treat this condition? आपका यही question आएगा. How will you approach this condition after? 6-month-old baby है, उसको हम कैसे ठीक करेंगे? What will you tell the patient's mother or the father? How will you control this? So the most important thing is laryngomalacia is never treated surgically forefront. हम time लेते हैं laryngomalacia में. Why? Because we know by age of 2 to 3 years, laryngeal muscles, laryngeal cartilages will become more dense, more thickened. So the first line management of laryngomalacia is never surgery. First line management of laryngomalacia is always wait and watch. Wait and watch. We will tell the patient to prone the baby. We will tell proning of the child. Right? Correct, Vidushi. So we will prone, right? We will prone. We will try to give the patient thick formula feeds. try thick formula feeds. So instead of giving liquids, because again that will not be tolerated by the baby, they give thick feeds so that the patient does not have failure to thrive. Only in cases, so usually this improves by 2 to 4 years of age on its own. Only in cases if the patient's SpO2 is falling below 90%, if the child has got failure to thrive, in those cases we might choose to do a surgery if the child is really sick. What is the surgery that we will do for laryngomalacia? The surgery that we do for laryngomalacia, दो सर्जरी होती हैं. Surgical management is epiglottopexy and supraglottoplasty. अब ये बहुत इंपॉर्टेंट नाम है, supraglottoplasty. अब इसको ऐसे सोचो, बहुत सिंपल है, राइट? What is supraglottoplasty? What is epiglottopexy? Epiglottopexy, इसका मतलब क्या हुआ? This epiglottis is curled, right? तो हमें इसको क्या करना है? वी हैव टू अनकर्ल इट. अनकर्ल करने के लिए, ताकि बंद ना हो, व्हाट वी डू? वी टेक अ सूचर फ्रॉम द एपिग्लॉटिस एंड टाई इट टू द टंग. हम टंग पे सीधा एक टाई मार देते हैं, सो दैट दिस एपिग्लॉटिस डज नॉट फॉल बैक. दैट इज कॉल्ड एज एपिग्लोटोपेक्सी. मतलब बेस ऑफ टंग से एपिग्लॉटिस को जोड़ देना ताकि इट डज नॉट कर्ल बैक व्हेन द पेशेंट इज इंस्पायरिंग, वो खुली रहे. दैट इज कॉल्ड एज एपिग्लोटोपेक्सी. सुप्राग्लोटोप्लास्टी क्या होती है? दैट वी नीड टू इंक्रीज द स्पेस. So we give 2 release incisions over the aryepiglottic folds. इसको release कर देते हैं. So if we release, suddenly this larynx will become a little bigger. This is called as supraglottoplasty. मतलब हमने supraglottis का plasty repair किया by just opening or releasing these aryepiglottic folds, and they have now improved in size. These are the 2 surgeries what you should know. बस that finishes what is laryngomalacia. खत्म. चलो अब आते हैं नेक्स्ट इंपॉर्टेंट थिंग पे. नाउ दिस इज ऑल्सो समथिंग विच इज रिलेटेड टू अ चाइल्ड. दिस इज ऑल्सो समथिंग विच इज रिलेटेड टू समथिंग एसोसिएटेड विद स्ट्राइडर. 4-year-old child presents with a history of chronic stridor. This is something important. Chronic stridor that has worsened over the past few months. Okay, the child also experiences recurrent episodes of respiratory distresses there. Okay, there is particularly on exertion. On examination, you note, you got the point, biphasic stridor. अब द मोमेंट आपने biphasic stridor सुना, 3 things आपके दिमाग में आ गई. That biphasic stridor कहां होता है? Either this is at the level of vocal cord, or this is at the level of subglottis, or this is at the level of cervical trachea. This is what we have discussed, correct? So biphasic stridor means it rules out supraglottis, it rules out bronchi, it rules out thoracic trachea, and there is evidence of respiratory distress with intercostal retractions. Okay, which of the following conditions is most likely to be the child's symptoms? So these are the things that they have given. Laryngomalacia produces inspiratory stridor, cannot be the answer, क्योंकि this is something which is related to inspiration, right? Tracheomalacia could be tracheomalacia, because trachea में हो सकता है narrowing हो गई हो. Subglottic stenosis हो सकता है, because subglottis भी biphasic stridor में आता है. And vocal cord paralysis is something which does not produce biphasic stridor as the primary symptom, तो हम इसको भी हटा देते हैं. अब हमारे पास 2 ऑप्शन बचते हैं, tracheomalacia and subglottic stenosis. Remember one important point. Tracheomalacia कभी भी आपसे क्वेश्चन पूछा नहीं जाएगा. This is one thing I am telling you from NEET PG perspective. Right? Tracheomalacia, if they tell you as a question, they will only ask you post thyroidectomy, बहुत बड़ा goiter था, patient end up into stridor. That might be because of tracheomalacia. But generally, children are not with tracheomalacia, not born with tracheomalacia so common. Most common cause for biphasic stridor in children still happens to be subglottic stenosis. Remember this line. Most common cause for biphasic stridor is subglottic stenosis. Now, if I show you what is this subglottic stenosis, आपको क्या दिखेगा? आपको ये दिखेगा. Right? So you do a laryngoscopy, you see there are these 2 vocal cords, and just below the level of the vocal cords there is what area? Below the level of the vocal cords there is something called as subglottis. Glottis मतलब vocal cords, below the vocal cords is subglottis. Right? So just let me show you how the subglottis is. So you have got your cricoid cartilage, और cricoid cartilage के नीचे होता है trachea. Right? There is trachea below the cricoid cartilage. Correct? Now, what happens is inside this area, inside the cricoid cartilage, जो ये area होता है, we call this area as subglottis. That is why below the level of the vocal cords, within the cricoid cartilage is subglottis. Right? Okay? Now, one important thing. If this area gets narrowed, then there will be circumferential narrowing of this area. क्योंकि अब कोई जगह नहीं है. And if it gets circumferentially narrowed, there will be a very pinpoint hole which you will be able to see through this vocal cord. बिल्कुल एक pinpoint hole की तरह है. The answer is subglottic stenosis. अब एक चीज और इंपॉर्टेंट आती है, सबग्लॉटिक स्टेनोसिस में विदुषी इज सेइंग दैट प्रोलॉन्ग्ड इंट्यूबेशन की हिस्ट्री नहीं है. इट इज नॉट इंपॉर्टेंट टू गेट दैट हिस्ट्री. Subglottic stenosis is of two types. There are two types of subglottic stenosis. One is called as congenital, one is called as acquired. So there are two types of subglottic stenosis. Congenital, acquired. हो सकता है बच्चे के पैदा होने के बाद ही congenital stenosis हो, right? It is never important to have an acquired cause always. Congenital का मतलब ये है कि that this patient has been born with a very small cricoid cartilage. अब cricoid cartilage ही small है, तो ऑब्वियसली सबग्लॉटिस भी स्मॉल होगा, तो पेशेंट के इवेंचुअली दे विल बी सबग्लॉटिक स्टेनोसिस. सो दीज कंजेनाइटल कॉजेज आर बिकॉज ऑफ अ स्मॉल और इलिप्टिकल cricoid cartilage, and this is usually a feature of certain syndromes such as Pallister-Hall syndrome, Down syndrome, DiGeorge syndrome, and Pierre-Robin syndrome. These are the common syndromes which are associated with a congenitally small subglottis, right? अब आपको क्वेश्चन जनरली नीट में क्या आता है, आपको कंजेनाइटल का नहीं आता, आपको जनरली नीट में क्वेश्चन आता है कि रिपीटेड इंट्यूबेशन होते रहे पेशेंट के. अगर रिपीटेड इंट्यूबेशन होते रहे पेशेंट के, सो देयर वाज कांस्टेंट ट्रॉमा दैट वाज हैपनिंग ओवर द सबग्लॉटिस, मतलब बार बार इंट्यूबेशन ट्यूब से, देयर वाज कांस्टेंट ट्रॉमा, एंड बिकॉज ऑफ द कांस्टेंट ट्रॉमा इट क्रिएटेड अ लॉट ऑफ fibrous tissue formation which led to stenosis. So the most common cause of acquired subglottic stenosis happens to be endotracheal intubations, repeated endotracheal intubations. तो हमने इंट्यूबेशन रिलेटेड दो चीजें देखी, वन इट कुड बी एरिटेनॉइड ग्रैन्युलोमा, अनदर इट कुड बी सबग्लॉटिक स्टेनोसिस. Okay, it could also occur because of granulomatous lesions, because that also produce a lot of destruction of mucosal tissue, and they could also occur because of burn injury. So burn injury, granulomatous lesions, anything will produce destruction of mucosa, and that will eventually lead to stenosis, that will eventually lead to fibrous tissue formation. Okay, now one important question, how will you ग्रेड दिस स्टेनोसिस? ग्रेडिंग क्या होती है स्टेनोसिस की? दिस इज व्हाट दे आस्क यू, राइट? क्योंकि ग्रेडिंग के बेसिस पे मैनेजमेंट है. सो द ग्रेडिंग ऑफ दिस पर्टिकुलर स्टेनोसिस happens by Cotton-Meyer grading or Cotton-Meyer staging. There is something called as Cotton-Meyer staging of subglottic stenosis. There are 4 stages of Cotton-Meyer of subglottic stenosis. If there is a stenosis of 0 to 50%, we will call it as grade 1. मतलब 50% तक subglottic area has been narrowed. Okay? If there is something which is from 51 to 70%, we will call it as grade 2 stenosis. If this particular stage is between 71 to 99%, we will call it as grade 3 stenosis. And if it is complete obstruction, you can't see any hole, then it is grade 4 obstruction. Now, on the basis of this grade, there are treatments for subglottic stenosis. Okay? If the patient comes in the first grade or second grade, in the first or second grade, yani if the patient is coming between first and second grade, how will you treat that? We usually do something called as a surgical approach. So how do we treat a first to second grade? We do something called as laser excision and balloon dilation. Laser excision and balloon dilation. That is the approach for grade 1 and grade 2 stenosis. Okay, that is the first point. Grade 1 or grade 2, laser excision and balloon dilation. Now, how do we do laser excision? Laser excision का मतलब, suppose this is a stenotic segment, right? We will put a cruciate incision. Cruciate मतलब 4 corners में we will create this kind of a cut, right? And when we cut this, then we will do serial dilation with a balloon. हम इसके अंदर balloon लगाएंगे, and that balloon will expand this area after getting cut. So this is called as serial dilation. So we have to give at least 5 to 6 times serial dilations with the balloon after we have released the stenotic segment. Right? Okay? So we do laser excision with serial balloon dilation. अब इसी में एक important question आता है that अगर we have given a laser excision, then that laser excision later on it will fibrose again. So क्या कोई drug है that we can apply at this stenotic segment? Is there any drug which after doing a laser excision we apply at the edges of the excision? So there is a drug which is a very important question which we don't not only apply with subglottic stenosis but we also apply this drug in choanal atresia, in cases of dacrocystorhinostomy. In many cases we do that, but that drug is called as mitomycin C. It is application of mitomycin C. Mitomycin C is an anti-fibroblastic drug. It is an anti-fibroblastic drug. What does it do? It decreases the cross-linking of DNA. It inhibits the cross-linking of DNA. तो अगर cross-linking नहीं होगी, there will be no replication of DNA. अगर DNA replication नहीं होगा, there will be no fibroblast. If fibroblast नहीं होंगे, तो fibrosis नहीं होगी. So as simple as that. That is why it is an anti-fibroblastic agent which we apply on the edges. This happens in grade 1 and grade 2 stenosis. Now what about treating grade 3 and grade 4 stenosis? हम grade 3 और grade 4 कैसे करेंगे? So grade 3 and grade 4 stenosis is usually treated by a direct surgical approach where we remove the stenotic segment और उसको हम लोग कहते हैं cricotracheal resection and anastomosis. Cricotracheal resection and anastomosis. So इसका मतलब क्या हुआ? What do you understand by cricotracheal resection and anastomosis? Let's say this is your thyroid cartilage. This is your thyroid cartilage. This is your cricoid cartilage and this is your trachea, right? Now there is a stenosis that has happened in this area, right? तो अब हम क्या करते हैं? We remove a part of the trachea and the cricoid completely. ये हम हटा देते हैं. Okay, so let's just take it out. अब इसको हम हटा देते हैं. So now we have removed this area of the cricoid and the remaining trachea. The remaining of the trachea, we pull it up. We pull up the remaining trachea and we suture it to the undersurface of the thyroid cartilage. This is called as cricotracheal resection and then reanastomosis. Okay, fine, right? So this is something what you need to understand about. What do you understand by cricotracheal resection? What do you understand by reanastomosis? And how do you do that? So this is something which we do in cases of complete obstruction or grade 4 stenosis or maybe grade 3 stenosis, which is not working out with laser excision and mitomycin C. Okay. एक और इंपॉर्टेंट चीज होती है जिसे हम कहते हैं क्रिकॉइड स्प्लिट. सो द सेकंड सर्जरी दैट वी डू इज कॉल्ड एज एंटीरियर क्रिकॉइड स्प्लिट विद रिब ग्राफ्टिंग. विद रिब ग्राफ्टिंग. अब ये क्या होती है? दिस इज ऑल्सो अ क्वेश्चन विच इज बीन आस्क्ड वन टाइम इन INI-CET. सो व्हाट इज दिस? इसका मतलब ये है कि दिस इज योर थायराइड कार्टिलेज, दिस इज योर क्रिकॉइड कार्टिलेज, दिस इज योर ट्रेकिया. करेक्ट? यहां पे स्टेनोसिस हो रखी है. ओके, सो व्हाट वी डू, वी क्रिएट अ काइंड ऑफ an opening in the cricoid. हम cricoid को खोल दिया, right? And we take out all the stenotic segment. हमने पूरा stenosis हटा दी. अंदर की we have removed all the stenosis. देखो हमने अंदर की सारी stenosis हटा दी, right? अब ये cricoid को हमें खुला रखना है. We have to increase the size of the cricoid. So what will we do? We'll take a rib and we will attach a rib over here so that this cricoid increases in size. So this is called as an anterior cricoid split. We split the cricoid, we open it up, clear up all the stenosis, and now we don't attach it back. We interpose it with the help of a rib so that we get more space in this particular area for the patient to breathe. This is called as an anterior cricoid split together with a rib graft. Other than that, we do cricotracheal resection and anastomosis. This is how we approach subglottic stenosis cases, right? एक common question और आता है, अगर subglottic stenosis में हम कोई stent लगाते हैं, if we keep an airway stent in subglottic stenosis, in order to maintain the patency, what is the name of that stent or airway stent? It is called as Montgomery stent. Montgomery stent is a stent which is an airway stent which is used in cases of subglottic stenosis. ये stent होता है जो हम रख देते हैं so that the patient does not have a recurrence of subglottic stenosis. Okay, fine. These are the potential questions. इससे ज्यादा कुछ नहीं पूछा जाता. Okay, चलो. अब आते हैं next question पे. Next scenario of larynx. That is scenario about a 45 or 45-year-old male who presents with a painless soft swelling in the neck. Okay, now there is a neck swelling that enlarges during Valsalva maneuver. बस यहीं पे ये लाइन खत्म हो गई. एक swelling है neck पे जो Valsalva maneuver पे increase होती है, right? Now this disappears when he swallows. Okay, that is something also there. He reports occasional hoarseness of voice. On examination, you see a translucent mass is visualized in the neck, just lateral to the thyroid cartilage. Thyroid cartilage यहाँ है, इसके lateral में there is a mass, which increases on Valsalva maneuver, which moves with swallowing also. Swallowing में भी move करता है. What is the likely diagnosis according to the patient symptoms? ठीक है, अब यहां पे दो चीजें इंपॉर्टेंट है. एक स्वेलिंग है which is mobile on swallowing and it is lateral to your thyroid cartilage. करेक्ट, यहां पे lateral to your thyroid cartilage. अब इसमें एक एक करके रूल आउट करना स्टार्ट करते हैं. सबसे पहला है थायरोग्लॉसल डक्ट सिस्ट. फर्स्ट, थायरोग्लॉसल डक्ट सिस्ट मूव्स विद डिग्लूटेशन, करेक्ट. मूव्स विद टंग प्रोट्रूजन, अगर हम टंग बाहर निकालते हैं दैट ऑल्सो इट मूव्स, करेक्ट. बट इट इज अ मिड लाइन नेक स्वेलिंग. इट इज नॉट अ लैटरल नेक स्वेलिंग. इट इज नॉट लैटरल टू द थायराइड. इट विल बी डायरेक्टली सेंटर में, मिड लाइन में, बिकॉज थायरोग्लॉसल डक्ट कम्स इन द मिड लाइन above your hyoid bone. So first thing that rules out the thyroglossal cyst is that it is something which is lateral to the thyroid, so it cannot be thyroglossal duct cyst. नहीं हो सकती क्योंकि it is lateral. Second, thyroglossal duct cyst, will it increase on valsalva? उसका कोई रोल ही नहीं है. valsalva में वो चीज इंक्रीज करेगी which has got some connection with the larynx. एक चीज याद रखना, because larynx में ही हवा जाएगी, the whole air will go into the larynx and the swelling will increase in size. So that cannot be with the thyroglossal cyst. It's the thyroid swelling. So this answer will become wrong. Branchial cleft cyst is another swelling which is present lateral to the thyroid. It is not in the midline, right? So it is on the lateral side. But again, branchial cleft cyst has got nothing to do with valsalva maneuver, has got nothing to do with hoarseness of voice, has got nothing to do with movement on deglutition. So it cannot be branchial cleft cyst. And this is a congenital swelling. This is not going to be a history of a patient who has noticed it suddenly. Okay. Third question आता है laryngocele और goiter. Goiter again is a thyroid swelling. It moves with deglutition, but again that is a generalized swelling which moves with deglutition. It's a thyroid swelling. It has got nothing to do with valsalva maneuver. It has got nothing to do with hoarseness of voice. So ruled out. Only one thing remains, क्योंकि ये valsalva में increase कर रही है, the air is coming from the larynx. It has to be laryngocele. अब laryngocele होती क्या है? That is something we need to figure out, right? Laryngocele का मतलब ये है that there is air present in an abnormal space which is called as saccule. Now what is saccule? I'll tell you. First, I want you all to remember the coronal section of the larynx. Coronal का मतलब if I cut open the larynx in this direction, मैंने ऐसे काटा larynx को and I show it to you. So if I cut my larynx and I show it to you in this direction in a coronal plane, how will it be? सबसे ऊपर larynx में कौन सी bone होती है? सबसे ऊपर where the larynx attaches, it's our hyoid bone, right? तो सबसे ऊपर हो गई hyoid bone, ये भी hyoid हो गई, ये भी hyoid हो गई. I've removed because I've cut open, right? This is hyoid bone. Below the hyoid is what? Below the hyoid is your thyroid cartilage. So below the hyoid is your thyroid cartilage. You've got this as your thyroid cartilage. Very good. So this is your thyroid cartilage. What membrane of the larynx is present between thyroid and hyoid? कौन सी membrane होती है? It is thyrohyoid membrane. Thyrohyoid membrane is present between thyroid cartilage and hyoid bone. Correct? What is below the thyroid cartilage? Below the thyroid cartilage is cricoid cartilage. ये भी हमें पता है. So below the thyroid cartilage is our cricoid cartilage. So this is our cricoid cartilage. So this you can see two ends क्योंकि मैंने ऐसे काट दिया है. I've cut open in a coronal plane and I've opened the larynx for you. So there is hyoid, thyroid, cricoid. Cricoid के नीचे क्या होता है? Trachea. That's something we know, right? So cricoid के नीचे आ गई trachea. The tracheal rings that come. So these are the tracheal rings, right? What attaches the thyroid cartilage to cricoid cartilage? It is cricothyroid membrane. What attaches the cricoid cartilage to the tracheal ring? It is cricotracheal membrane. These are the membranes of the larynx, right? What we do in our cases. And finally, you have got the membranous trachea. Same चीज यहाँ पे, it is all the membranous trachea which comes below, right? Now, what are the areas of the larynx? हम यहीं पे discuss कर लेते हैं. This is very, very important. Okay? If I draw the cut section of the larynx, then the larynx will somewhat come like this. It will go up. It will go anterolaterally. It will come down. And then finally, it will come down like this. Again, on the opposite side, it will come like this. It will go up. It will go up anterolaterally. Then it will come down. And finally, it will come down like this. This is how a cross section of the larynx looks like. अब इसमें क्या-क्या parts हैं? What do you see in the cross section of the larynx, right? So I have drawn these two projections. एक ऊपर एक नीचे. The upper projection is called as a false vocal cord. Lower projection is called as a true vocal cord. One is a false vocal cord above. There is true vocal cord below. Okay? Now very important. What is the area of the larynx present above the level of vocal cords? ये कौन सा area है which is above the level of true vocal cords? This is supraglottis. So supraglottis is the area which is present above the level of true vocal cords. That is the supraglottic area, जिसमें हम epiglottis होती है, false vocal cords होते हैं, aryepiglottic folds. These are all parts of our supraglottis, right? The part present between the vocal cords, this area is called as glottis. This area is called as glottis. Okay? Now, if we draw one imaginary line 1 centimeter below the level of true vocal cord. If I draw 1 centimeter below the level of vocal cord, one imaginary line, 1 centimeter below the level of vocal cords, and another imaginary line along the lower border of cricoid cartilage. The area present here, this area is called as subglottis. So what is the subglottis? The subglottis is an area which is present, if I draw an imaginary line 1 centimeter below the true vocal cords and another imaginary line below the level of the cricoid cartilage. इसके बीच के area को we call it subglottis. Okay? Now what is laryngocele? Laryngocele is a particular condition where there is increase in transglottic pressure. Transglottic pressure increases. Now what is transglottic pressure? Any patient who is a trumpet player or any patient who is a glass blower, trumpet player or glass blower will have what? अगर कोई trumpet बजाता है या glass blow करता है, suddenly their pressure increases in this area. Suddenly the pressure rises up at the level of vocal cords. Now there is a space which is present between the false vocal cord above and the true vocal cord below. एक छोटी सी space है. And this little space which is present between the false vocal cord above and the true vocal cord below, this space is called as laryngeal ventricle. This is called as laryngeal ventricle. What is ventricle? Ventricle is a space present between the false vocal cord above and the true vocal cord below. The ventricle dilates laterally into a space which is called as saccule. That means ventricle is dilating laterally into a tiny little space which is called as saccule. And saccule contains certain important seromucinous glands. इसके अंदर seromucinous glands होते हैं. Okay? That is why जो ये seromucinous glands हैं, ये secrete करते रहते हैं fluid, which is why our false vocal cord and true vocal cord get lubricated. That is why saccule is also given the name as oil can of larynx. This is also an important question. Oil can of larynx क्या होता है? It is our saccule. What is saccule? It is an extension of the ventricle. What is ventricle? It is a space between the true vocal cords below and the false vocal cord above. Okay? Now, if there is a patient who has got increased pressure at this area, suddenly this air can get trapped within the saccule, and this saccule can get abnormally dilated and it can come out through the thyrohyoid membrane as a swelling. This swelling which comes out through the thyrohyoid membrane, which is containing air because of the abnormal dilation of the saccule, is given the name as laryngocele. Okay? Now one important question. अगर मैं swelling को press करूं, इस swelling को if I press, then this swelling will produce a gurgling sound. What is the name of that sign? What is the name of the sign if I press a laryngocele and that produces a kind of a sound, which is a hissing to gurgling sound? That sign is a very important question for you in your NEET PG exams, and that sign is called as Bryce sign. It's called as Bryce sign. So what is Bryce sign? It is a gurgling or a hissing sound which is produced on compressing over on a laryngocele. Right? Now, if I show you what is the X-ray picture of this particular patient, जो पूछी जाती है, if you see over here, this is a AP as well as a lateral view of the neck, correct? And in the AP and lateral view of the neck, what do you see? You see an air-filled translucent shadow. So you can see an air shadow. You can see an air shadow. And this air shadow is present lateral to the neck, lateral in the neck. So if this air shadow will be present lateral in the neck, the answer will become laryngocele. Now always remember one thing that will happen in trumpet players, glass blowers, they will give you that example. Okay, fine. So this finishes about how exactly a laryngocele looks like. What sign do we get? We get Bryce sign. ठीक है? अब एक important जो question इससे और आता है, that laryngocele का management क्या है? How do you manage a laryngocele? So if it is a small laryngocele, then we do something called as marsupialization. That means open the laryngocele and keep it. उसे book की तरह open कर देते हैं. That is called as marsupialization. अगर laryngocele large होती है, then we do something called as transcervical excision. Transcervical excision. This is what is the approach for laryngoceles. Okay, that's all. Now we have finished about a lot of things, right? And we have finished about what exactly is laryngocele. Now let's move on to something more. अब ये बहुत important question है. This is also about a child, 4-year-old male, progressive worsening of hoarseness. And whenever I say a child, hoarseness हमें कैसे पता चलती है? When they cry. So usually when this child cries, the child has got a hoarse voice. Okay? And there are intermittent episodes of stridor. Intermittent का मतलब आते जाते, right? And these episodes have been lasting since the past 6 months. That is what is the history of this child. He is born with a normal vaginal delivery at full term with unremarkable perinatal history. So this child, if they have given you some kind of a birth history, that has got some important significance, right? So there is a normal vaginal delivery which has been happened with this child, okay, but there was nothing wrong with the child. Flexible laryngoscopy was done and it reveals multiple pink exophytic lesions covering the true vocal cords and extending up till the subglottic region. So now there is something related to the vocal cords where they have seen some kind of polypoidal lesions, right? The rest of the larynx appears normal. There is no evidence of any neck lymphadenopathy. There is nothing wrong in any other examination. So we have got a child who has hoarseness of voice, who has got stridor, and this child has presented to us with multiple exophytic lesions over on the level of vocal cords and below in the subglottic area. What are you thinking this could be? Let me show you how this child's larynx looks like. This is how the larynx looks like. And what are we seeing here? We are seeing multiple kind of polypoidal exophytic lesions that are present over on both the vocal cords. They are extending into the subglottic area. What it could be? What are you thinking that this particular answer could be? Child has got a hoarseness when it cries. Child was a normal vaginal delivery. So what are you thinking about? Why they have given this history of a normal vaginal delivery? Why they have given a full term history? Why they have shown you this kind of a picture? So let me just go into what they are asking. Number one, laryngeal trauma. That could not be the answer because laryngeal trauma से related कोई history नहीं है. There is nothing called as forceps delivery which has been done. So obviously it cannot be the answer. Vocal cord nodules cannot happen because I already told you that is something because of chronic voice abuse at anterior and mid 1/3 of the cord. It cannot be the answer. Juvenile laryngeal papillomatosis and laryngeal carcinoma. Carcinoma is obviously never common in such young age group, so it has to be juvenile laryngeal papillomas which are the most common here. अब ये सबसे important question है, इसमें क्या question आते हैं, right? So what is juvenile onset respiratory papillomatosis? What do you understand by the term JORP? JORP means juvenile onset recurrent respiratory papillomatosis. That means this is the condition where there are multiple papillomatous growths or exophytic lesions which are formed over the vocal cords as well as in the subglottic or supraglottic area. Now the causative organism for this JORP is human papilloma virus. And usually the strains 6 and 11, very important asked question. 6 and 11 causes what? 6 and 11 causes benign lesions such as juvenile onset papillomatosis and genital warts. What are the malignant strains for HPV? The malignant strains for HPV are 16 and 18. Most malignant strains. So whenever we talk about cancers, it is about 16 and 18. Right? अच्छा. अब HPV क्या करता है? HPV is an epitheliotropic virus. HPV loves epithelium. It is an epitheliotropic virus. That is why it sits inside the epithelium and starts growing and forming these kind of lesions. Right? What is the most common site for JORP? The most common site for JORP is the free edge of the vocal cords. Free edge of vocal cords. This is the most common site for juvenile onset respiratory papillomatosis. Okay? Now coming to the next question. Whenever I say juvenile, they would be multiple. जब भी मैं बोलूं adult, they will be solitary. एक चीज इंपॉर्टेंट होती है. Juvenile papillomas are always multiple grape-like. So you see, this is a multiple grape-like picture. But had it been an adult, this would have been a single solitary papilloma. Okay, fine. Now, how exactly will you treat this particular condition? What is your take on treatment? How will you treat this condition? So very commonly, the first thing that we do in treatment is medical line of management, and then we do surgical line of management. मेडिकल लाइन ऑफ मैनेजमेंट में वी नीड टू गिव एंटीवायरल ड्रग्स. What is the first line antiviral drug? It is cidofovir. Cidofovir is a drug of choice. Okay, so usually we have got intralesional cidofovir, or we can even give cidofovir injections. Okay, or either we can inject it directly inside these lesions. Recently, there has been a drug which has been added in order to treat juvenile papillomas, and that drug is bevacizumab. It is a monoclonal antibody. So monoclonal antibody में recent advance bevacizumab. Remember that. बस यही याद रखना है. Okay? What is the surgical management of this particular condition? The surgical management of this particular condition is laser excision. Now remember one important thing. Laser excision का क्या मतलब है? Whenever we put a laser, we put CO2 laser or something, right? We have to keep our cells covered completely. Why? This has been a question to you. Why do we need to cover everything like a mask, eye? Everything has to be covered during excision of HPV associated lesions. The reason is laser से जो smoke उठती है, the smoke of the laser is given the name as plume. Plume is called as the laser associated fume. So laser के fumes को plumes बोलते हैं. And whenever those plumes go inside or we inhale them, accidentally we can get this virus inside us also, and it can lead to those kind of lesions even in the surgeon. That is why we need to be very careful in excising juvenile papillomas whenever we are excising them out. Okay? Now, if I tell you that इस बच्चे का suppose airway compromised है, इस बच्चे की सांस नहीं आ रही, you need to take a decision about the airway. What will you do? Will you do an endotracheal intubation? Will you do a tracheostomy? This is my question to all of you. What will you choose to secure the airway of this patient? अगर मुझे इसमें, let's say patient has come in stridor, मुझे इसका airway संभालना है. I want to somehow ventilate this child. What should I choose? Should I go for an intubation? Should I go for any kind of like an invasive procedure like tracheostomy? How should I approach the airway of this child? So this is something that you should think about. क्या करें? Okay, so always remember, tracheostomy is not the first point advantage in juvenile papillomas. Tracheostomy should be avoided. Tracheostomy should be avoided. अगर कोई चारा नहीं है, then we will do a tracheostomy. But unless and until tracheostomy नहीं करनी चाहिए. Why you should avoid a tracheostomy in papillomas? Because आपने जब tracheostomy करी, you have created a passage for these papillomas to spread. So accidentally they may come out through the skin also. So there would be high chances of recurrence. So you should always choose to, for an endotracheal intubation, if you cannot intubate the patient, then do a tracheostomy. That is something which you save it for the last. Okay, fine, chalo. So this finishes about what you understand by juvenile angiofibromas. Chalo, now we come to another important child. Now this is about a 4-year-old previously healthy child. Kuch nahi problem hai. And now the child presents to the emergency department with sudden onset of high fever. Fever se matlab inflammation. Matlab I am talking about some kind of an inflammatory condition. Okay. The patient has got severe sore throat. Okay. There is pain and there is difficulty in swallowing. Now, the child also appears to have drooling of saliva, and the child is sitting in a position which is called as tripod position. But the child is sitting just like this. They're keeping the hands in front, they've raised their head in front, and they're sitting like this, like a tripod. Okay, that's a tripod. Okay. Now, on examination, there is a pronounced distress with the child refusing to lie down and exhibiting inspiratory stridor. जैसे वो लेटता है, the child ends up into stridor. The neck is hyperextended and the tongue is protruded. Direct visualization of the oropharynx नहीं करते हैं due to a risk of airway obstruction. What is this particular condition that we are talking about? Now, I think Lucian is saying C, epiglottitis. Okay, let me just show you the boy. This is the boy, how the boy is sitting. This is called as tripod position. This is called as tripod position. Now, I've got a question from Jhansi Prabhakar that Zenker's diverticulum and laryngocele both are lateral swellings. Good question. Zenker's diverticulum या pharyngeal pouch भी lateral swelling है, laryngocele भी lateral swelling है. First is on the basis of history. Whenever you see a patient who is a trumpet player or a glass blower who has got an increased transglottic pressure, जिसकी swelling is related to increase in Valsalva maneuver, the answer would be laryngocele. There are no chances where the patient will end up with a pharyngeal pouch with this. Pharyngeal pouch usually happens because of an outpouching of the pharyngeal mucosa through the Killian's dehiscence. That means इसमें जो primary symptom patient का होगा will be regurgitation of food, will always be halitosis, will always be intolerance of food, will always be weight loss, emaciation, vomiting. These are the primary symptoms of a pharyngeal pouch. Two important signs. If you press a laryngosele, it produces a hissing sound that's called as Bryce sign. If you push a pharyngeal pouch, it produces a gurgling sound that is called as Boy's sign. So Boy's sign for pharyngeal pouch, Bryce sign for a laryngosele. Okay, so now you guys get it. Pharyngeal pouch, the investigation of choice becomes barium swallow. For a laryngosele, it is plain X-ray or a CT scan. Okay, right? Now, this is the tripod position. सबने सही बताया, it is epiglottitis. अब ये epiglottitis है क्या? इससे important question. It is an acute inflammatory condition of the larynx, right? Acute inflammatory condition of the larynx means it is an acute inflammation of supraglottic structures. Not only the epiglottis, but it is an acute inflammation of the supraglottic structures. Now, this is a bacterial condition. Remember that. When I talk epiglottitis, it is bacterial, not viral. When I say croup, it is viral. Epiglottitis will occur in school-going children. Croup will happen in children who are much younger, less than 2 years old. So 6 months to 2 years, you get a history of fever and laryngeal inflammation, that is croup. You get in a 4 to 6 year old child, that is epiglottitis. Okay. Now, second important thing, what is the most common organism in children for epiglottitis? It is Haemophilus influenza. That is why we have got so many vaccines against Haemophilus influenza, which we give towards the school-going age. If we talk about an adult, what is the most common cause of adult? It is Streptococcus pneumoniae. Now we have got a surge of Streptococcus pneumoniae, which has been recently added as now, which is more dominant than H influenza in causing epiglottitis. Okay. So most common cause in children, Haemophilus influenza; in adults, Streptococcus pneumoniae. Now comes the important clinical features, right? Whenever there is an inflammation of the epiglottis, right, patient will always develop, I told you, stridor. Supraglottic stridor kaisa hoga? Supraglottic stridor will be inspiratory, right? So this patient will have inspiratory stridor. So that means the patient will sit in front like this in order to get more space. Otherwise, the child will get into supine position, the stridor will increase. So the child will sit forward, and this position is called as tripod position. This is also a very important question, okay? One more important point. If I do a laryngoscopy, I don't have a picture over here, but if I do a laryngoscopy, if let's say I'm seeing through a laryngoscope inside, this epiglottis will appear cherry red in color. It will appear red. It will look angry. So if I get cherry red epiglottis, this is also called as a cherry red sign. It is a sign which is seen in epiglottitis. Okay, right? Now, if I do an X-ray of this baby, right? So if I do an X-ray of this baby, what will I see? So you see a thumb-like projection of the epiglottis. You see, this is the lateral X-ray of the soft tissue neck, and you see that the epiglottis is like a thumb. It has increased in size considerably. What is this called as? This is called as thumb sign. So thumb sign is seen in what? Thumb sign is seen in epiglottitis. Okay? Now, एक और इसमें sign दिखता है X-ray में. That is also very important. अब ऐसे याद रखो that let's say this is the tongue. ये tongue है, and this is the epiglottis. There is a ligament which joins the tongue to the epiglottis, and the ligament which joins the tongue to the epiglottis, this is called as median glossoepiglottic fold. Median glossoepiglottic fold is a fold or a mucous ligament which connects the base of the tongue to the epiglottis. The space present between the tongue and the epiglottis is called as vallicula. What is vallicula? It is a space present between the tongue and the epiglottis. That is called as vallicula. अब ऐसे सोचो, अगर ये epiglottis becomes very large in size, it becomes like a thumb, ये बहुत बड़ी हो गई, so what will happen? This is called as thumb sign. ये दिख रहा है thumb sign. But one more thing has happened. If this grows in size, the vallicula will become obliterated. The vallicula will not be seen. That is why you cannot see the vallicula very well over here. And this is called as absent vallicula sign. So two signs on X-ray, one is absent vallicula sign, one is thumb sign. Because now the epiglottis is so big that it will obliterate the vallicula. Okay, fine. Now, if I tell you कि ये particular history एक 4-year-old boy की नहीं है. Let's say I'm talking about a 6-month-old boy. I'm talking about a 6-month-old boy. And I give you a triad. और triad क्या है? Triad है that the patient has got seal-like cough or barking cough, barking seal-like cough, or if the patient has got severe retractions and the child has got stridor which is biphasic. What is your diagnosis? 6-month-old child or 3S. What is the 3S? seal-like cough, which is barking cough, severe retractions, and stridor, which is biphasic. What are the 3S got to do? 3S क्या होंगे? So whenever you get 3S, remember one thing. I am talking about croup. I'm talking about croup, not epiglottitis. So epiglottitis में primary feature barking cough नहीं होता. It is inspiratory stridor. But whenever I'm talking about croup, what is the primary feature? The primary feature will become seal-like barking cough. It will become severe retractions of the chest, and the patient will end up into stridor, which is biphasic. Biphasic का मतलब it is either in the subglottis or the cervical trachea. That's what I told you. And this is what is seen in cases of croup. Croup का मतलब होता है laryngotracheobronchitis. This is another important NEET PG question. Laryngotracheobronchitis. Right? That means the cervical trachea and the subglottic area has become narrowed, significantly narrowed, and it has become edematous. Now, what is the difference between epiglottitis and croup? ये important question आता है. Epiglottitis, I told you it is a bacterial disease. School-going children. Croup is a viral disease. So, most common cause of croup is para-influenza virus. ये important question है. Croup के clinical features क्या होते हैं? It is seal-like barking cough, it is severe retractions of the chest, and it is stridor, which is biphasic. This is the 3S of S, which is again croup or laryngotracheobronchitis. Okay? So most important cause of laryngotracheobronchitis is para-influenza virus. अब इसमें कौन सा साइन दिखता है? What do you see in cases of croup? So you see this is your cervical trachea. हमेशा एक चीज याद रखना, whatever you see black on an X-ray is air, right? So center में trachea होता है and you see suddenly the tracheal shadow has become narrowed. ये बिल्कुल narrow हो गई पेंसिल की तरह. This is called as steeple sign. This is called as steeple sign. चर्च का जो ऊपर का पार्ट होता है ना, that is called as a church steeple. So that is what is called as steeple sign. ये चर्च का टॉप पोर्शन दिख रहा है. That's called as a steeple sign. This is also called as a pencil tip sign. This is also given the name as wine bottle sign. It looks like a pencil tip. It looks like a wine bottle. Okay, right? So seal-like cough का मतलब जो seal होती है ना, seal. Whenever the seal barks, जब वो आवाज निकालती है, तो वो आवाज एक barking आवाज होती है, right? You seal is an animal, right? So it creates a sound. That's what is called as seal-like barking cough. अब इसके लिए I'll tell you a mnemonic. How to treat epiglottitis या croup. Epiglottitis या croup का treatment क्या है? So it's my very easy 6H mnemonic. The 6H mnemonic for treatment of epiglottitis and croup. कोई भी बच्चा epiglottitis या croup के साथ आता है, I treat it by this 6H. So how do I treat it? Number 1, hospitalization. सबसे पहले hospitalize a child. Hospitalization. That is the first thing that we will do. Second, हम लोग क्या करेंगे? That अब child की obviously इतनी narrowing हो गई है, तो अब उसको breathing देनी है, right? So whenever we need to give the breathing, we need number 1 head end elevation. We know epiglottis will fall back अगर बच्चा सोएगा. So we need the epiglottis to stay straight so that more and more air will go. So there will be head end elevation. Third H will be humidified oxygen. Start the patient on humidified oxygen support. That is the third H. कोई भी बच्चा आया with laryngotracheobronchitis, कोई भी बच्चा आया with epiglottitis, same treatment. Fourth H is high grade antibiotics. High grade antibiotics. Right? Which is usually penicillin and cephalosporins. Okay? Fifth H becomes hydrocortisone. Hydrocortisone क्या है? Hydrocortisone is a steroid. We inject directly hydrocortisone. Hydrocortisone से edema कम होगा. Suddenly the edema will reduce. Suddenly the airway will become better. Right? And finally, sixth H is high dose nebulized racemic epinephrine. Racemic epinephrine. Now what do you understand by racemic epinephrine? रेसिमिक एक मिक्सचर होता है, राइट? जो हम लेबोरेटरी में बनाते हैं, डेक्स्ट्रोरोटेटरी, लिवोरोटेटरी फॉर्म्स को मिला के रेसिमिक मिक्सचर बनाते हैं. सो एपिनेफ्रिन इज अ sympathomimetic drug. It increases sympathetic activity, right? What type of epinephrine is what type of drug? Epinephrine is a non-selective alpha and beta agonist. Non-selective. तो ये एपिनेफ्रिन जब जाएगा अंदर, सो इट विल ऑल्सो एक्ट ऑन द अल्फा 1 रिसेप्टर्स. अल्फा 1 रिसेप्टर्स आर प्रेजेंट ऑन ब्लड वेसल्स, दैट विल कॉज वेजोकॉन्स्ट्रिक्शन, सिंपैथेटिक एक्टिविटी, वेजोकॉन्स्ट्रिक्शन. तो जब वेजोकॉन्स्ट्रिक्शन होगा तो ऑब्वियसली एडिमा कम होगा. बीटा रिसेप्टर्स आर प्रेजेंट ऑन द स्मूथ मसल्स, बीटा 2 रिसेप्टर्स. तो स्मूथ मसल्स जब एक्ट करेंगे तो इट विल लीड टू ब्रोंकोडाइलेशन. So this epinephrine, when you nebulize it and give it to a child, alpha 1 receptors will get activated, they will cause vasoconstriction. Beta 2 receptors will get activated, they will lead to bronchodilation. And that is how the child will breathe better. ये mnemonic है for treating any child who comes to you with epiglottitis or who comes to you with croup. Finished. तो हमने सारी laryngeal conditions about inflammatory conditions पढ़ ली. But एक important चीज है which still remains to me regarding inflammatory conditions. Okay, so we move on to the next one. Now we have got a 40-year-old male who presents with a 3-month history of progressive hoarseness, dysphonia and sensation of throat discomfort. Dysphonia मतलब sound different आ रहा है. There is hoarseness of voice and there is sensation that something is stuck in my throat. Okay. Now he also reports a low-grade fever, night sweating and unintentional weight loss of over 5 kilograms over the past 2 months. Weight गिर रहा है, some kind of low grade fever है, night में sweating है. Which disease do you think produces these kind of symptoms? Think about the disease. Think about हमें कोई low grade fever आ रहा है, weight गिर रहा है, सबसे पहले आप क्या suspect करते हैं? What do you suspect inside you? That could be the reason for unexplained weight loss, unexplained night sweats, unexplained low grade fever. In India, carcinomas will not produce fever. Carcinomas में fever is not the main problem. ये एक infection हो सकता है ना? This could be an infection which produces low grade fever, right? सोचो, carcinoma में I'll always give you a history of any particular thing which is a smoker. Let's say smoking है बहुत सालों से, गुटखा chewing है, tobacco chewer है, alcoholic. But this is something which is related to something. Correct महक? It is always TB. TB is one disease जहां पे सबसे common ये 3 चीजें दिखती हैं, right? Now, if we do a laryngoscopy of this patient, हमें कुछ इस टाइप के symptoms दिखाई देते हैं. We see all of this in what? So the answer here lies in just reading the first line of the question. That is, अगर आपको दिखा unexplained weight loss, night sweats, low grade fever और larynx में hoarseness, think about that this patient is of a TB and TB की वजह से it had led to tuberculous laryngitis या TB larynx. So now I'm going to cover about very important aspect of what is TB laryngitis. Now when I say TB laryngitis, कुछ चीजें आपको पता होनी चाहिए, कुछ चीजें आपको याद होनी चाहिए, right? TB laryngitis means now the laryngeal tissue has got tubercle bacilli and now that are causing chronic inflammation of the laryngeal tissue. We call it tuberculosis of the larynx. Okay. Now what do you see in cases of TB laryngitis? See here, ये vocal cords दिख रहे हैं, right? इसमें से देखो, अगर एक vocal cord red है, एक vocal cord white है, so this means that only one vocal cord is inflamed. First clinical sign for TB laryngitis is monocorditis. Monocorditis. Monocorditis means one vocal cord is inflamed and red. That is the first feature of laryngeal TB. Okay. Now let's come to the second. Second हम देख रहे हैं बहुत गंदे 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 ये पिंक कलर के ग्रैन्युलेशंस हैं. एंड वोकल कॉर्ड पे भी देखो इस तरीके के क्रेटर लाइक बन चुकी है, मतलब वोकल कॉर्ड्स आर नॉट स्ट्रेट, वोकल कॉर्ड्स हैव बिकम लाइक दिस, these kind of lesions have come. ये ऐसे लग रहा है कि कोई चूहा आया और उसने ऐसे निबल कर लिया पूरे लैरिंग्स को. तो दिस इज कॉल्ड एज अ माउस निबल्ड अपीयरेंस. ये आपका क्वेश्चन आता है, माउस निबल्ड अपीयरेंस ऑफ वोकल कॉर्ड्स. ये क्वेश्चन डायरेक्टली आता है. माउस निबल्ड अपीयरेंस ऑफ वोकल कॉर्ड्स इज सीन इन व्हाट? इट इज सीन इन टीबी, राइट? और एक कॉर्ड पे इंफ्लेमेशन विच इज कॉल्ड एज मोनोकॉर्डाइटिस. अब थर्ड क्या इसमें दिखेगा? थर्ड आप देख रहे हैं ये डर्टी डर्टी अल्सर्स बन रहे हैं बिटवीन द एरेटिनोइड्स. सो दिस इज कॉल्ड एज इंटर एरेटिनोइड मैमिलेशंस. मैमिलेशंस का मतलब नोड्यूल्स. सो यू विल सी इंटर एरेटिनोइड मतलब दो एरेटिनोइड के बीच में बहुत सारे नोड्यूल टाइप के या ग्रोथ टाइप की निकल आएंगी, छोटी 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 छोटी. दैट इज कॉल्ड एज इंटर एरेटिनोइड मैमिलेशन. And fourth important sign of TB is edema of epiglottis. This is called as turban epiglottis. This is also a very important feature. So turban epiglottis is seen in TB, monocorditis seen in TB, interarytenoid mammalation seen in TB, mouse nibbled appearance of vocal cord seen in TB. सब कुछ TB laryngitis. सिंपल। तो ये सारे 4 फीचर टीबी के, अनएक्सप्लेन्ड वेट लॉस टुगेदर विद क्रॉनिक कॉफ, हिमोप्टिसिस, ये सारे फीचर टीबी के होंगे ही, बिकॉज दिस इज यूजुअली सेकेंडरी टू पल्मोनरी टीबी, मैक्सिमम केसेस। ओके, हाउ डू यू ट्रीट इट? ट्रीटमेंट इज ऑब्वियसली एटीटी, एंटी ट्यूबरकुलर ड्रग्स और एंटी ट्यूबरकुलर थेरेपी, खत्म। ओके फाइन, चलो नाउ वी मूव ऑन टू द नेक्स्ट क्वेश्चन। ओके, अब आते हैं नेक्स्ट क्वेश्चन पे। 55 ईयर ओल्ड मेल स्मोकर। अब देखो यहां मैंने स्मोकर दे दिया। स्मोकर देने का मतलब है आई एम थिंकिंग अबाउट समथिंग, और मैंने आपको क्या बताया था, स्मोकर्स लैरिंग्स 2 होते हैं, या तो स्मोकर जब मैं दे रहा हूं मेनली द फोकस इज आइदर ऑन रिंकीज और ऑन कैंसर, 2 ही चीजें हो सकती हैं, राइट? ओके, सो मैक इज आस्किंग आइदर इट बाय हेमाटोजेनस और लोकल, इट कुड बी बोथ। हेमाटोजेनस इज रेयर, मोर कॉमनली इट इज पल्मोनरी टीबी सेकेंडरी टू इट, क्योंकि बार बार वो कॉफ करेगा तो ऑब्वियसली लैरिंग्स विल आल्सो गेट bathed with that sputum and that will lead to tuberculous laryngitis. Okay, 55-year-old male smoker presents with a hoarse voice, so there is hoarseness of voice that has persisted for the past 6 months. persistent hoarseness है. Okay, hoarseness को हम when do we worry about hoarseness? कब हम worry करना चाहिए? If the hoarseness is persisting for more than 14 days, then we should always undergo a laryngoscopy. तो मतलब वो persistent है, 2 वीक से ज्यादा hoarseness हमें address करनी पड़ती है. So this is about, he denies any history of dysphagia, weight loss or hemoptysis. मतलब they have already ruled out the other thing, that is TB, which I already taught you, right? Flexible laryngoscopy करी, it reveals a solitary exophytic lesion on the right true vocal cord measuring approximately 1.5 centimeter in diameter with well-defined margins. So everybody, spam is saying C, Parul is saying C, सब लोग बोल रहे हैं it is a vocal cord carcinoma. Okay, अब let me just show you एक बार, तो देखो ये डर्टी टाइप का एक्सोफिटिक लीजन है राइट ट्रू वोकल कॉर्ड पे। तो इफ एवरीबॉडी इज सेइंग वोकल कॉर्ड कार्सिनोमा, तो आंसर वोकल कॉर्ड कार्सिनोमा ही है। तो इसमें हमें याद रखनी है 2 चीजें। इफ दे टेल यू समथिंग रिलेटेड टू अ स्मोकर with voice change which is persistent, and the third symptom that they give you is that this particular patient has no other history, there is only hoarseness, or maybe they have some kind of dysphagia, or they might give you a history of ear pain, always think of that this all they are talking about is a carcinomatous lesion, और ये dirty exophytic lesion होगा। पॉलिप होता, इट वुड हैव बीन पेडंक्यूलेटेड, पॉलिप हो नहीं सकता, नोड्यूल हो नहीं सकता बिकॉज इट हैपेंस बायलैटरली, इट इज सिमेट्रिकल, राइट? This cannot be a papilloma, right? Papillomas are again, you will find papillomatous growths which are fragile, which are well defined. This is something which is dirty to look at, right? This is exophytic, this is dirty, right? So this is something which predominantly states this is a carcinoma. अब मैं आपसे पूछता हूं 2 important question related to carcinoma. There is something called as supraglottis, glottis and subglottis. इनमें से best prognosis किसकी होगी, worst prognosis किसकी होगी? Which among the following has got best prognosis? Best prognosis किसकी होती है, worst prognosis किसकी होती है? Whether it is glottic carcinoma, supraglottic carcinoma or subglottic carcinoma, right? What has the worst prognosis? So remember one thing, the best prognosis of any cancer in the larynx is glottic CA. Glottic carcinoma की best prognosis है, worst prognosis is subglottic carcinoma. Why is the glottic carcinoma having the best prognosis? The best prognosis is because the glottis does not have lymphatics. Vocal cords में कोई lymphatics नहीं होती. That is the reason कोई भी lymph node involvement नहीं होता. That is why glottic carcinomas are the most common carcinomas also, and they are also very easily treatable, less recurrence. But subglottic has got the highest amount of lymphatic spread. It spreads to level 4 nodes, it spreads to level 6 nodes, level 5 nodes, and this is the reason, because it spreads into lower nodes, it becomes a problem. That is why subglottic carcinomas are a dangerous carcinoma. Glottic carcinomas have the best prognosis among them. ठीक है? अब इसी के बेस पे हम लोग स्टेजिंग पढ़ लेते हैं। अब यहीं पे स्टेजिंग खत्म कर लेते हैं और मैनेजमेंट भी खत्म कर लेते हैं, क्योंकि दिस इज समथिंग दैट इज द मोस्ट प्रॉब्लमैटिक सिचुएशन व्हिच कम्स, राइट? ग्लॉटिक कार्सिनोमास। So let's figure out the staging, right? TNM staging. T staging के हिसाब से we have got T1 tumors which is divided into T1A, T1B. What is T1A carcinoma? A का मतलब एक, मतलब कि if there is a vocal cord carcinoma on one vocal cord, एक A, one vocal cord involvement and both the vocal cords are freely mobile, मतलब मोबिलिटी ऑफ द कॉर्ड्स में कोई प्रॉब्लम नहीं है, बोथ द कॉर्ड्स आर मोबाइल, एडक्टिंग एबडक्टिंग, बट एक कॉर्ड में ग्रोथ है. यू कैन सी वन कॉर्ड हैज अ ग्रोथ, बट बोथ द वोकल कॉर्ड्स, इफ आई टेल यू दे आर फ्रीली मोबाइल, देन व्हाट डज इट बिकम? 1A, A फॉर एक, B मतलब बोथ. अगर ये कॉर्ड दूसरा भी चला गया, both the vocal cords have a swelling with a lesion, then if both vocal cords are involved but still both vocal cords are mobile, mobility में कोई प्रॉब्लम नहीं है, I tell you mobility is normal, then you will say it is T1B, both vocal cords involved, both vocal cords mobile, T1B. Okay, so 1A means a chord both mobile, 1B both chords both mobile. Now comes T2. T2 का मतलब हुआ नाउ द कैंसर हैज स्प्रेड बियॉन्ड द वोकल कॉर्ड्स, अब वो कहीं और चला गया है, राइट? सो इफ द कैंसर हैज स्प्रेड इनटू आइदर द सुप्राग्लॉटिस, वो ऊपर चला गया, और इनटू द सबग्लॉटिस विद इंपेयर्ड मोबिलिटी ऑफ द कॉर्ड. इंपेयर्ड मोबिलिटी वर्ड है, इंपेयर्ड का मतलब पूरी तरीके से कॉर्ड मूव करना बंद नहीं किया है, बट स्लगिश हो गया है, समवॉट रिस्ट्रिक्टेड हो गया है, दैट इज कॉल्ड एज T2. तो T2 का मतलब नाउ one or more subsite is involved. One or more subsite का मतलब either the tumor has extended to supraglottis or subglottis with impaired mobility of the cord. अब इतनी अच्छी मोबिलिटी नहीं रही, that is called as T2, impaired mobility. अब ये वर्ड याद रखने हैं, impaired. अब आता है T3. 3 का मतलब फिक्स्ड. जहां मैंने बोला वोकल कॉर्ड फिक्स्ड हो गया है, ऑटोमेटिकली योर ध्यान शुड गो T3 हो चुका है. ऑटोमेटिकली जहां बोला फिक्स्ड, T3 हो चुका है. दैट मीन्स नाउ वन वोकल कॉर्ड इज नॉट मोबाइल एट ऑल, राइट? नाउ व्हेन आई से फिक्सिटी ऑफ द कॉर्ड, व्हाट एल्स विल बी T3? T3 में देयर विल बी सर्टेन इन्वॉल्वमेंट ऑफ अदर एरियाज ऑल्सो, और इसका निमोनिक है 4P. 4Ps. 4Ps कौन से? इफ आई टेल यू दैट द ट्यूमर हैज इन्वॉल्व द प्री एपिग्लॉटिक स्पेस, मतलब एपिग्लॉटिस के सामने द ट्यूमर हैज इन्वॉल्व द स्पेस, और द ट्यूमर हैज इन्वॉल्व द पैराग्लॉटिक स्पेस, or the tumor has involved the perichondrium of the thyroid cartilage, or the tumor has involved into the post-cricoid area. P for post-cricoid, P for perichondrium of thyroid, P for paraglottic space, P for pre-epiglottic space. चारों P. So अगर किसी भी P 4P में चला गया, parapharyngeal space नहीं, not the parapharyngeal space. Parapharyngeal space जब आती है तो we talk about nasopharyngeal carcinomas. That is separate. ये लैरिंग्स में, दिस इज नॉट गॉन मोर लैटरल. पैराफेरेंजियल स्पेस में आ गया, इट विल बिकम T4. ओके, सो दिस इज समथिंग दैट इज T3. 4P टुगेदर विद फिक्सिटी ऑफ द कॉर्ड्स, इट इज T3. नाउ आई कम टू T4. T4 का मतलब T4A एंड T4B. T4A का मतलब द लैरिंग्स का ट्यूमर हैज इन्वेडेड इनटू एनी अदर प्लेस अराउंड द लैरिंग्स. लैरिंग्स के बाहर आ गया ट्यूमर. अब लैरिंग्स के बाहर क्या क्या होता है, खुद सोचो. लैरिंग्स के बाद सारी कार्टिलेजेस हैं, कार्टिलेजेस ऑफ द लैरिंग्स आर इन्वेडेड कंप्लीटली. ट्रेकिया हैज बीन इन्वॉल्व्ड, ईसोफेगस हैज बीन इन्वॉल्व्ड, ये जो बाहर की स्किन है दिस हैज बीन इन्वॉल्व्ड, स्ट्रैप मसल्स आर देयर, दे हैव बीन इन्वॉल्व्ड, कैरोटिड शीथ के पास देयर इज रिकरेंट लैरिंजियल नर्व, दैट हैज बीन इन्वेडेड, थायराइड ग्लैंड हैज बीन इन्वेडेड. सो एनीथिंग व्हिच इज नेक्स्ट टू द लैरिंग्स, खुद सोचो, एनीथिंग व्हाटएवर इज देयर, ट्रेकिया, ईसोफेगस, स्ट्रैप मसल, स्किन, कुछ भी उन्होंने बताया, दैट विल बी T4A. दैट मींस एनी एक्स्ट्रा लैरिंजियल स्ट्रक्चर, if it is involved, the problem has gone into T4A, right? And finally we come to T4B. T4B में mnemonic है PCM. Physics, chemistry, maths नहीं, but this is prevertebral area, prevertebral space, carotid sheath and mediastinum. तो तीन चीजें याद रखनी है, carotid, mediastinum, prevertebral space, PCM. If it gets involved, automatically it is T4B, मतलब final stage हम कुछ नहीं कर सकते. बट उसके ऊपर इफ इट इज देयर इन एक्स्ट्रा लैरिंजियल एरिया वी कॉल इट T4A. ठीक है, अब क्वेश्चन क्या आते हैं, हाउ विल यू अप्रोच दीज क्वेश्चंस. अब इसमें क्या आप देंगे, लेट्स से आपके पास ये पेशेंट आया, इसके दोनों वोकल कॉर्ड्स मोबाइल है, द ट्यूमर इज ओनली ऑन वन वोकल कॉर्ड, दैट मींस दिस इज अ T1A ट्यूमर. हाउ विल यू अप्रोच दिस केस? तो रिमेंबर वन थिंग, इफ द लैरिंग्स की ट्यूमर इज इन स्टेज 1 और स्टेज 2, द प्राइमरी ट्रीटमेंट इज सिंगल मोडालिटी. सिंगल मोडालिटी मतलब एक मोडालिटी का ट्रीटमेंट बहुत है. Either in T1 and T2, either we give the patient radiation alone, हम radiation ही देते हैं, or we do something called as laser micro excision. Okay, or we call it as TLM, that is trans laser excision of the lesion. That means laser से हम इसको excise कर देते हैं. Okay, so either we give single modality, या तो हम radiation alone देंगे, or either we give a microlaryngeal excision with the help of a laser. That are the two things we can do, one modality only. Now let's come to T3. ये प्रॉब्लम है सबसे बड़ी. T3 का मतलब क्या हुआ? T3 का मतलब दिस इज अ ग्रे जोन. ग्रे जोन का क्या मतलब है? ना इधर है ना उधर है. एंड T3 में कंफ्यूजन आती है. तो T3 में हम क्या करते हैं? हाउ डू वी डिसाइड वेदर वी शुड गो फॉर सर्जरी और वी शुड गो फॉर कीमो रेडिएशन? T3 is something we follow, something called as organ preservation protocol. Now what do you understand by organ preservation protocol? तो initially क्या होता था? T3 में कोई भी ट्यूमर आता था तो as surgeons we are very happy to take out cancers because we need to excise it out. हमें मजा आता है, but ऐसा नहीं है. We need to, if we take out the whole larynx, voice will go. That is something which is very very bad. तो हमें क्या करना है? We need to preserve the organ as well. We need to think about it. तो इसमें क्या हुआ? देयर वाज अ फाइट बिटवीन द सर्जन्स एंड द रेडिएशन ऑन्कोलॉजिस्ट कि ऑर्गन प्रिजर्वेशन करो, ज्यादा खेचाता नहीं करने की जरूरत नहीं है. तो व्हाट डिड दे स्टार्ट डूइंग? दे सेड कि लेट्स डिफाइन आवर प्रोटोकॉल्स. इफ द पेशेंट इज नॉट एस्पिरेटिंग, हैज गॉट ओके रेस्पिरेशन एंड द स्पीच इज फाइन, वी विल गिव द पेशेंट कीमो रेडिएशन. दैट मीन्स हमने तीन चीजें देखी. स्पीच ऑफ द पेशेंट, एस्पिरेशन है कि नहीं और रेस्पिरेशन हो रहा है कि नहीं. If there is blockage in respiration, aspirate कर रहा है patient, मतलब कि larynx is not functional. What is the point to keep the larynx? Right? So in those cases, if there is problem with speech, aspiration, respiration, take it out. Do a laryngectomy. Do a laryngectomy. If there is no problem with speech, aspiration, respiration, then give chemoradiation. This is what T3 tumors are all about. Organ preservation protocol. तो अगर आपसे लेकिन ये पूछा जाए that what is the first line of management in T3, तो पहले line of management में chemo radiation ही बोलना, because your answers in your textbook says chemo radiation. That's what I'm telling, but I want to grain that knowledge inside you कि अगर in real life if you see these patients, you just don't close your eyes, say chemo radiation. नहीं, we see the speech, we see aspirate कर रहा है कि नहीं, larynx functional है कि नहीं functional है, send it for surgery, क्योंकि क्या रखने का फायदा, right? So this is something, when you are asked a question, write chemo radiation in T3. Okay? चलो, अब T4 में तो ऑब्वियसली हमारे पास कुछ ऑप्शन ही नहीं बचा. T4 है मतलब ग्रॉस एक्स्ट्रा लैरिंजियल एक्सटेंशन है. सो वी डू अ TL. TL मींस टोटल लैरिंजेक्टमी विद नेक डिसेक्शन. So we take out the neck nodes completely bilaterally and we do a total laryngectomy. Okay? T4B is something we cannot do anything and we give a patient palliation chemotherapy. Palliation chemo means we just increase the life of the patient as much possible, but this is something which is not operable. We cannot do much about it, unfortunately. That is T4B. ये आपका अप्रोच रहेगा to all the larynx questions as far as laryngeal tumors are concerned. ठीक है, चलो अब ये खत्म होता है हमारा CA larynx. चलो, now I come to my last scenario for today. Right, this covers all your larynx scenarios. इससे बाहर कुछ नहीं है. Okay, so this is about Miss Sarah Miller, a 45-year-old marketing professional who presents with an anterior neck swelling and is diagnosed with a large multinodular goiter requiring total thyroidectomy. So there is a huge thyroid and she requires a thyroidectomy. Okay? Preoperative laryngoscopy confirms normal vocal cord mobility. कोई problem नहीं है. There's normal vocal cords before the thyroidectomy. अब हमने thyroidectomy कर दी. So now post-operative extubation is also initially uneventful. ठीक रहा. Everything was fine. But however, several hours later, Miss Miller appears to have a husky voice and there is mild stridor. अब ये प्रॉब्लम आ गई है. Stridor आ गया है and there is mild husky voice. Total thyroidectomy करने के बाद. Now she complains of significant hoarseness, breathing difficulty and difficulty in projecting her voice. Project नहीं कर पा रहे हैं voice को. Right? What could be the particular condition and what has happened to this lady? So is it intubation granuloma, is it laryngeal papilloma, vocal cord carcinoma, palsy? So obviously vocal cord पहले चल रहे थे, अब नहीं चल रहे होंगे. There is nothing got to do with any lesion, right? The one lesion that could happen is an intubation granuloma, जो हम सोच सकते हैं कि हो सकता है maybe, but that won't produce stridor as a primary feature. So most common cause for vocal palsy all around the globe is what? It is total thyroidectomy, and that is why vocal palsy becomes the answer. That is why vocal palsy becomes the answer. Okay, now, and Meg is also right. One is an acute option and others are chronic options. So that is also something which is quite true. अब एक चीज इंपॉर्टेंट है. Now I'll tell you how to approach vocal palsy questions. ये क्या आपकी अप्रोच रहेगी vocal paralysis के केसेस में. ठीक है, पहला क्वेश्चन आपसे जो पूछा जाएगा, व्हाट इज द मोस्ट कॉमन कॉज ऑफ वोकल पैल्सी या व्हाट इज द मोस्ट कॉमन कॉज ऑफ RLN पैल्सी? द आंसर विल बी थायरॉइडेक्टमी. Answer will be thyroidectomy. Okay, fine. Now, second important question that they will ask you is, right recurrent laryngeal nerve is injured most commonly during. It is thyroidectomy. Left recurrent laryngeal nerve palsy occurs because of most commonly. It is mediastinal causes. What is the most common mediastinal cause for vocal palsy? It is bronchogenic carcinoma. These are the set questions which they will ask you. So right has got a more chance of developing an iatrogenic injury. Why? Because right is more superficial and horizontal. Left is more deep. But left comes from the mediastinum up. That is why mediastinal causes has got a longer, that's why left has a longer course. So more of mediastinal causes like bronchogenic carcinomas or apex of the lung tumors will produce this particular condition. ठीक है, चलो अब एक इंपॉर्टेंट क्वेश्चन आ जाता है, एंड आई वांट यू ऑल टू रिमेंबर टू थिंग्स ओवर हियर, टू थ्योरीज ऑफ वोकल पैल्सी. पहली थ्योरी को हम लोग कहते हैं वेगनर एंड ग्रॉसमैन हाइपोथेसिस. दिस थ्योरी आई वांट यू गाइस टू रिमेंबर. वेगनर एंड ग्रॉसमैन हाइपोथेसिस क्या होती है? नाउ व्हाट एग्जैक्टली आर द नर्व्स व्हिच आर सप्लाइंग द लैरिंग्स? हमारी लैरिंग्स को दो नर्व सप्लाई करती हैं. One is recurrent laryngeal nerve and one is superior laryngeal nerve, right, which are supplying the muscles of our larynx. Recurrent laryngeal nerve supplies all the intrinsic muscles of the larynx. सारे abductors सबको सप्लाई करती है RLN, except for one. One muscle is not supplied by RLN. This is your question. Which of the following muscles is not supplied by RLN? It is cricothyroid muscle. Cricothyroid muscle is the only muscle which is not supplied by RLN. It is supplied by external branch of superior laryngeal nerve. External branch of superior laryngeal nerve supplies cricothyroid muscle. RLN बाकी सारी intrinsic muscles को supply करता है. Which is the only muscle which is an abductor of the vocal cord? Abductor मतलब बाहर ले जाने वाली कौन सी मसल होती है? So the only abductor of vocal cord is posterior cricoarytenoid muscle. That is why it is also called as the safety muscle of larynx, because it actually takes away your vocal cords out. तभी आप breathing करते हैं, because it helps your larynx to open. That's why it's also called as the safety muscle of the larynx. That's the only abductor of the vocal cord. Rest all are adductors. What is the function of cricothyroid muscle? Function of cricothyroid muscle is adduction and tension of vocal cord. Adduction plus tension of vocal cords करती है cricothyroid. ठीक है, अब हम इसी के नॉलेज पे यहां पे आ जाते हैं इनटू वेगनर ग्रॉसमैन हाइपोथेसिस. व्हाट इज दिस, राइट? अब यहां पे मैं एक लैरिंग्स बनाता हूं. लेट्स से दिस इज योर लैरिंग्स. ओके, दिस इज योर बेस ऑफ टंग, दिस इज योर एपिग्लॉटिस, दिस इज द एपिग्लॉटिस, दिस इज द एरी एपिग्लॉटिक फोल्ड विद द एरिटेनॉइड्स, राइट? एंड दीज आर योर टू वोकल कॉर्ड्स. दीज आर द टू वोकल कॉर्ड्स. Okay, now they are more, they obviously they are abducting and they are adducting. अब चार सिनारियो हो सकते हैं. There could be four scenarios which I will give you. एक सिनारियो आपके पास ये आ सकता है आपके क्वेश्चन में कि RLN इंजर हो गई यूनिलैटरल. एक सिनारियो आ सकता है RLN इंजर हो गई बायलैटरल. एक सिनारियो आ सकता है RLN इंजर हो गई प्लस SLN इंजर हो गई यूनिलैटरल. एंड एक आ सकता है RLN एंड SLN बोथ आर इंजर्ड बायलैटरली. मतलब दोनों इंजर हो गए. रिकरेंट लैरिंजियल नर्व, सुपीरियर लैरिंजियल नर्व, बोथ इंजर्ड, वन इंजर्ड, ओनली रिकरेंट लैरिंजियल इज इंजर्ड, यूनिलैटरल एंड बायलैटरल. दीज आर द फोर टाइप्स ऑफ क्वेश्चन यू विल गेट इन योर पेपर्स. कि क्या सिनेरियोस में हम क्या करेंगे, व्हाट विल बी द अप्रोच. नाउ सी, इट्स वेरी इजी एंड आई एम गोइंग टू मेक इट वेरी सिंपल फॉर यू. ठीक है, व्हेन वी रीड लैरिंग्स, वी रीड इट अंडर थ्री सिम्टम्स. तीन ही सिम्टम होते हैं लैरिंग्स के. वन इज स्पीच. लेट मी जस्ट टेक दिस आउट. So I'm just writing it. One is speech, one is aspiration, one is respiration. और इन्हीं तीन symptoms के basis पे we will try to figure out what will happen to if they will get injured. Okay? Now let me come back to the Wegener-Grossman hypothesis that I told you. Wegener-Grossman hypothesis ये कहता है that if the patient has got recurrent laryngeal nerve injury, the vocal cord will obtain a paramedian position ड्यू टू द अनअपोज्ड एक्शन ऑफ क्रिकोथायरॉइड मसल। अब इस पूरी लाइन का क्या मतलब है? इसका मतलब यह है कि हमें पता है कि क्रिकोथायरॉइड इज सप्लाइड बाय सुपीरियर लैरिंजियल नर्व। तो इन केस अगर किसी भी इंडिविजुअल के आरएलएन इंजरी होती है, रिकरेंट लैरिंजियल इंजर हो गई, स्टिल द सुपीरियर लैरिंजियल इज वर्किंग, so that vocal cord will attain a paramedian position. Paramedian का मतलब that cord will now come in the center 1.5 mm away from the midline. इस तरीके से कॉर्ड आके खड़ा हो जाएगा. It will be 1.5 mm from the midline. ये ना तो एडक्ट करेगा ना एबडक्ट करेगा. It will be just standing like this 1.5 mm from the midline. Only the opposite side vocal cord will be functional. मतलब अगर सांस लेगा आदमी तो the other vocal cord will abduct. अगर सांस when the patient will speak, the vocal cord will adduct. But this red cord or this cord which has been paralyzed will stay in this direction only. And why is that? It's because the recurrent laryngeal nerve has been injured, तो adduct abduct नहीं कर सकता. But one muscle is still working. One muscle is cricothyroid muscle, which will be tensor of the vocal cord. It will attain or it will help this cord to attain this position. So if there is any particular condition जहां पे RLN injure हो गई, cricothyroid is still functional and it will cause unopposed tension and adduction of the vocal fold to attain a paramedian position. This is called as Wegener-Grossman hypothesis. Now you understand and tell me the first theory. अगर किसी के unilateral SLN palsy हो गई, let me just take this out. If a person has got unilateral RLN palsy, okay. Unilateral RLN palsy का मतलब one vocal cord will attain paramedian position, other vocal cord is still mobile. Other vocal cord is still mobile. What will be the problem with the speech, aspiration and respiration of this patient? Speech का मतलब दूसरा cord अभी भी ये cord ऐसे ही है. दूसरा cord is moving out in. That means this vocal cord is standing. Is there any problem with the speech over here? No. There would be mild hoarseness. Why? Because opposite side cord अभी भी काम कर रहा है. Only this cord is paramedian. So that means the speech of this individual will be fine. There will be mild hoarseness. Mild hoarseness. Will the patient aspirate? No, because the other cord is still mobile. It is closing the glottis. It is going away, again closing the glottis. अगर glottis close हो रही है, that means the patient will never develop aspiration. That means there will be no aspiration in such cases. And will there be any problem with respiration? No. Why? Because the other opposite cord is still moving. The patient will be able to still respire well. So respiration maybe there will be no problem. There will be normal respiration. So if the patient has got unilateral recurrent laryngeal nerve palsy, I can say one of my vocal cord will attain a paramedian position because of the unopposed pull of the cricothyroid muscle that is supplied by the superior branch of the external branch of superior laryngeal nerve. And the other vocal cord is still mobile. So in those cases, the only symptom that the patient will get is mild hoarseness. Right? Simple? Now, अगर इसको मैं laryngoscopy पे देखूं तो ये ऐसा दिखेगा. This is how your laryngoscopy picture will look like. You can see the other opposite cord is moving. It is moving. It is abducting. It is coming back. But ये abduct adduct नहीं कर सकता because of one thing, because its recurrent laryngeal nerve is not functional. So it will attain a paramedian position because of the unopposed pull of cricothyroid muscle. And the opposite cord is going to come down and compensate and cause adduction और ये फिर बाहर चला जाएगा, फिर अंदर आएगा, फिर बाहर चला जाएगा. So unilateral RLN palsy में the only thing that I can get as a possible symptom is mild hoarseness. Right? So how will I treat it? What will I do in this case? If the opposite side cord is coming and compensating well, I don't need to do anything. That is why in cases of recurrent laryngeal nerve unilateral palsy, we give conservative management. We give conservative management. We wait and watch. ये अपने आप ठीक हो जाता है. Okay? So conservatively treat unilateral recurrent laryngeal nerve palsy, not a problem. अब let's say हम thyroidectomy कर रहे थे और thyroidectomy में हमने दोनों साइड की RLN काट दी. Bilateral RLN injury has occurred. Bilateral RLN का क्या मतलब हुआ? If I cut bilateral RLN, that means bilaterally my cricothyroids are still functional. If bilaterally my cricothyroids are still functional, both my vocal cords will attain a paramedian position because of the unopposed pull of the cricothyroid muscle. They will come in the center like this. अब दोनों cords ऐसे ही हैं. They cannot abduct. Why? Because it is supplied by recurrent laryngeal nerve. My abductors are not working. My only tension of the vocal cord is there and adduction is there. और vocal cords ऐसे ही रहेंगे. Why? Because both the cricothyroids are still functional. So now what will this lead to? Bilateral अगर मैंने RLN injury कर दी, both the vocal cords will be just in the center. They will not open or close. वो ऐसे ही रहेंगे. And this is something which will create what? This is a problem which will have no problem with speech, because speech दोनों vocal cords को साथ में रहना चाहिए. I'll have no problem with speech. I will have no aspiration, but now the patient will end up into stridor. That is the problem. So in bilateral RLN injury, the patient ends up into stridor. There will be no space for the patient to breathe. What is the operation that we do in cases of bilateral RLN injury? In bilateral RLN injury, the patient is always told to undergo Kashima procedure. This is a question. Kashima's procedure. What is Kashima's procedure? Kashima procedure का मतलब है we cut open the lateral 1/3 of the glottis. इतने में हम wedge shape excision करते हैं. We create a wedge in the posterior 1/3 of the vocal cords. We cut open. ताकि यहाँ पे थोड़ी open हो जाए, ताकि we can get some air. This is called as Kashima's procedure. Cutting off like a wedge the posterior 1/3 of the vocal cords. Okay? Another important thing that we do is lateralization thyroplasty. अब आपसे ये पूछा जाता है medialization कब, lateralization कब? Always remember, thyroplasty का एक निमोनिक है. टाइप 1, टाइप 2, टाइप 3, टाइप 4. 4 टाइप्स की थायरोप्लास्टी होती हैं. निमोनिक इज माइक्रोलैरिंजियल सर्जरी, MLS, और यहां पे बस लगा दो T. तो M मींस मीडियलाइजेशन थायरोप्लास्टी, L मींस लैटरलाइजेशन थायरोप्लास्टी, S मींस शॉर्टनिंग ऑफ वोकल कॉर्ड, T मींस टेंशन ऑफ वोकल कॉर्ड्स और लेंथनिंग ऑफ वोकल कॉर्ड्स. Now what do you understand by medialization? क्या हम यहाँ पे medialize कर सकते हैं? Medialize तो already हो रखा है. So what will we do? We will do lateralization thyroplasty. Lateralize करना पड़ेगा ना? So we will lateralize the vocal cords. इन दोनों को बाहर ले जाएंगे. That is called as lateralization thyroplasty. तो अगर मैं आपसे पूछूं, which among the following is going to be the treatment for RLN bilateral injury? You will tell me type 2 thyroplasty or lateralization thyroplasty. If I give you Kashima's procedure, you will say Kashima's procedure. So type 2 thyroplasty will be my choice here. That is another important point. Okay? अब आता है, let's say RLN, SLN दोनों इंजर हो गई. That means no muscle is functional. This is the easiest. अगर कोई भी functional नहीं है, no muscle is functional, SLN is injured, RLN is injured, all abductors are injured. What will now the cord will reach into? If both the SLN and RLN are injured, then the cord attains a cadaveric position. Very important question. कैडेवरिक पोजीशन को हम इंटरमीडिएट पोजीशन भी कहते हैं. What is cadaveric position? Now both the vocal cords will attain a position which is 3.5 millimeters away from the midline. And ये ना एडक्ट करेंगे ना एबडक्ट करेंगे, बस ऐसे ही रहेंगे. They will be 3.5 millimeters away from the midline and they will just stay like this. This is called as cadaveric position. That means in normal people we never see cadaveric position. One position of vocal cord we never see in a live person. It is cadaveric position. This position can only be seen when a patient has got bilateral SLN and RLN injury or unilateral SLN and RLN injury. जब पूरी तरीके से vagus injure हो जाती है, then this position is the only position that we will see. The other ways that we can see this position is in post-mortem, that if a patient has died or if the patient is under general anesthesia. So 3 points where you get intermediate या cadaveric position, which means both the vocal cords are 3.5 mm away from the midline. Either if it is post-mortem, or if the patient is under general anesthesia, or if there is complete recurrent plus SLN palsy, then you see cadaveric position. That means if you see here, both the vocal cords are 3.5 mm in the midline. बस खड़े हुए हैं ऐसे. They are not adducting nor abducting, बस ऐसे ही हैं. This is called as cadaveric position. Okay, so now let me just go back and tell you कि अब होगा क्या. See this. If I have unilateral SLN plus RLN palsy, that means one of my vocal cord is still functional. एक vocal cord जो है वो cadaveric चला गया, and let's say this vocal cord is still functional. ये adduct करेगा, abduct करेगा, adduct करेगा, abduct करेगा, but this vocal cord will stay just like this. So this vocal cord is not functional. This will stay like this. So what will happen to the speech? Will there be any closure of this glottis? No, because ये cord बहुत दूर है. So that means this patient will end up into aphonia. Aphonia. Will this patient aspirate? Yes, because my gap is still going to be there. So patient will develop aspiration. क्या respiration में कोई problem होगी? No, because there is enough space for the patient to breathe. So patient will have normal respiration. अब इसके केस में what can I do? इसके केस में the only thing that I can do is, in order to achieve the closure, I can actually shift this cord medially. अगर मैं यहां पे कुछ इंजेक्ट कर दूं तो ये कॉर्ड मीडियली शिफ्ट हो जाएगा. That means I can do medialization thyroplasty in these particular cases on the side where the cord is paralyzed. तो ये पैरालाइज कॉर्ड है, अगर मैंने इसमें कुछ इंजेक्ट करके इसको मीडियलाइज कर दिया, सो द ऑपोजिट कॉर्ड व्हेन इट इज मूविंग इट विल क्लोज द ग्लॉटिस completely. So if I tell you what is the treatment for complete SLN plus RLN palsy, you will tell me that the complete treatment is M, that means type 1 thyroplasty. You will do type 1 thyroplasty, which is medialization of the cord. Okay, fine. So you understood about RLN bilateral में करते हैं lateralization, RLN plus SLN unilateral complete palsy में करते हैं medialization of the paralyzed cord. अब फाइनल आ जाता है अगर दोनों बेकार हो गए. That means both the vocal cords are now away from the midline and they are stationary. ना वो move कर रहे हैं, कुछ नहीं कर रहे हैं. They are away from the midline 3.5 mm away. Now neither they will come adduct, neither they will abduct. They will stay like this. That means the patient will be having aphonia, the patient will be having aspiration, but respiration will be normal. But the larynx is completely non-functional. अब जो भी वो खाना खाएगा, the complete खाना will go inside into the trachea also. That's the issue. So what will be the treatment of choice in cases of RLN plus SLN injury? अब ये देखो, see this. Completely there is such a big gap between non-functional larynx. How will we treat this particular case? So in this particular case where we get bilateral RLN plus SLN injury, so in cases of bilateral RLN plus SLN injury, the treatment of choice becomes tracheoesophageal diversion. Tracheoesophageal diversion. And what do you understand by tracheoesophageal diversion? That means अब मेरा larynx काम नहीं कर रहा, right? So let's say ये larynx है. This is the larynx, right? This is the larynx. This is the cricoid. This is the trachea. And behind the trachea there is esophagus. Behind the trachea there is esophagus. Okay? And in front, let's say this is the skin. ये skin है patient की. Okay? अब हो क्या रहा है? What is happening is whenever this patient is eating food, the food is not only going into the esophagus, but it is also going into the trachea because the larynx is not functional. So what do we do? Laryngotracheal diversion. That means we need to stop aspiration, right? We need to stop aspirating the patient, otherwise everything will go into the lung. So how will we stop that? In order to stop that, what we will do is, we will cut the upper part of trachea. We will cut the upper part of trachea and we will suture it. One second. We will cut the upper part of trachea. And one end of the trachea, the upper end of the trachea, will suture it to the esophagus, and the lower end of the trachea will get it out through the skin. The upper end of the trachea we have diverted towards the esophagus, and the lower end of the trachea we have sutured to the skin outside. That means now the patient will have a permanent tracheostoma to breathe. और जो भी वो खाएगा, whatever he is aspirating through the larynx will directly go inside into the esophagus. This is called as tracheoesophageal diversion. We have gone and anastomosed the upper part of trachea to the esophagus because our larynx is not working. And the lower part of the trachea, we have sutured it to the skin. So there is a separate point where the patient will breathe. Bas. This finishes my whole of vocal palsy also. And this finishes my clinical masterclass on larynx scenarios also. So I hope you guys have understood. I hope you guys have enjoyed today's segment. I hope you guys have taken a lot of lessons. What can come as potential questions? These were all previous INI-CET, NEET PG, FMGE questions what I have spoken today. And I have tried to create some kind of a conceptual way, some kind of a way in which you can not only mug up these answers, but you can get the right option by excluding the diagnosis. That is all my purpose of today's lecture, that you know how to exclude a diagnosis, even if you're not understanding the primary statement. Right? So this is all for today. I hope you guys have enjoyed it. Thank you for joining. Thank you for being such an active participation. And if you have got any questions related to larynx scenarios, you're most welcome to ask me here itself. I'll be available all throughout. If you have any questions, we have a Telegram group. You can post it over on the Telegram group, or you can message me personally. Okay? So if there is no question, then I'll take your leave for today. Right? Thank you for joining. Thank you.